você começasse daí você segurar ele. Segurar o microfone. Entendeu?
Alô?
Por exemplo, se ela tirar o... É possível ela ficar do lado com o microfone na mão? Good morning, everyone. It's a great pleasure having you here. After a pandemic period, I think that's the first time that we are able here to do a symposium here at the University of Campinas at Piracicaba Dental School. Actually, at Piracicaba Dental School, not in University of Campinas. Probably they had a lot of several activities, but more related about the research group that I'm working with now. We were planning this meeting for a while, and now we are very happy about having this meeting here in Brazil. So it's a pleasure having you here with us in person. So welcome, everyone. First of all, I would like to, before we start the symposium, I would like to show you some information about why we are here. So there is a history and the group that's here as well. We have research from different parts of the world, different institutes, universities, and so I would like to point this before we start our talk. We are here because of this program. We have the International Partnership for Excellence, Education, Research and Innovation that is supported by the Research Council of Norway. So first, we were granted by a project that started in 2018. I'll show you later the dates. And it was among Norway, Brazil, and USA. So the group started the project in 2018. And then we got approved for a new round, so we got a new grant, and the family increased it. So now we have Norway, Brazil, USA, India, and Canada as well together in a new project. So you are going to see that sometimes you are going to talk about RESISPART, sometimes we are talking about RESISFORCE, but it's just the name about the name that we apply for the project. So the first one was RESISPART, and now we are going to work on the RESISFORCE, but they are going to be a little bit mixture as you are going to see. So as a short timeline, everything started when I did my PhD in 2018, 2012 at the University of Oslo. So from then, we kept a very good collaboration, so it was very good. I really recommend for the students to keep these good collaborations when you are outside the country and keep them. And then we were invited by Professor Fernanda Pettersen, that's the leader of the project. And then we got the grant for this first period. And then we had 2 meetings. We started the project in 2018, so we have a first meeting in USA. The second meeting we did here in Piracicaba Dental School. It was a similar way that you are here. We had a symposium in 2019, and we were planning the new meeting in Norway, but then we had the pandemics. So it was necessary to change the activities. We had some activities online, just keeping the group together, working together to keep the collaboration and the network. And after the RESISPART, actually, it was postponed, the end, because of the pandemics. And we applied for a new grant, and in 2020, it was approved, and we started now, in 2021, it was approved, and now we are having the new meeting related with the news project that's called RESISFORCE. So we are very happy to be the place that held the pre-pandemic meeting and now the post-pandemic meeting as well. So it's for us, for all the group, it was really nice. And now we are having this first meeting here at Piracicaba Dental School, and the symposium that we are doing today is part of the activities of the group. We are having activities the whole week. We still have some activities later, but the symposium is part of this activity. So as we had the first symposium called First RESISPART Symposium, then we decided to keep Second RESISPART Symposium. By the way, we are changing to a new project. So sometimes you are going to see RESISFORCE and RESISPART, but the structure and the collaboration just increase it. It's basically the timeline that it happened. So now we have 5 different countries. We have several universities and institutes working together. So we have from, I'm not sure, oh here, like University of Oslo is the leader institute. You have University of Campinas that's represented by us at dental school. UIC, Foresight, JCVI, McGill, TCS, the research group, and the late marriage hospital in India as well. And all of the things, the activities, they are supported by this INTERPART program that is supported by that's funded by the Research Council. So just some pictures about our last activities. So in 2018, we had like good opportunities. We participated in a meeting, and then the group came together to have activities related with the project. And then we start now, and then we had the second RESISPART meeting. So here we had the symposium as well, as you can see here, a picture at the end of the symposium. So it has been a very nice collaboration, and I'm very happy that all the major of the participants, they would be able to come and join us in this activity today. So it's just a small introduction, and I wish you all an excellent symposium. Just to go on in our activities, we invited the Vice Rector, Professor Maria Luisa. She was very happy to attend our meeting, and we were very happy having her with us as well. But unfortunately, because of the period that we're having now, we have some cases of COVID that is increasing. So she just indicated a person that she works with, and it's very good to have the Professor Plínio Trabasso here with us. She's a doctor as well. She's an infectious disease research, and he's the advisor of her office. So I would like to introduce you Dr. Plínio Trabasso, and he's going to talk a little bit about his expertise and about Unicamp as well in this area. Okay? Thank you very much.
So I don't have a presentation. I will all talk with you, okay? First of all, good morning, everyone. Good morning, Dr. Professor Antonio Pedro, Professor Flavio, who is the director of the Piracicaba Dental School. I'm very happy to be here. It's my great pleasure to be here. And I'm here in behalf, as Professor Antonio Pedro told you, I'm here in behalf of Professor Maria Luisa Moretti, who is the Vice Rector of the University, Campinas State University of Campinas. And first of all, I would like to thank you for this invitation to participate in this symposium. And I would like to express my satisfaction to be here in the end in person, because this is a very important issue in my personal research. I mean, antimicrobial resistance. And there is some other reasons to be here. The first is the choice of this November 18th. It's not a mere coincidence, because today is the beginning of the World Antimicrobial Awareness Week, who will last for 1 week until the next Friday, right? So it's I believe that this specific day was chosen by intent to mark this particular an important week to show the importance of the antimicrobial resistance. So in a certain way, this symposium marks the commitment of UNICAMP with the 17 Sustainable Development Goals of the United Nations, mainly the goal number 3, which that's the the healthy and well-being for everyone in every age. Yeah. And especially in goal number 9, particularly in regards with the fostering innovation. And my reference to innovation comes specifically from the INTERDISCIPLINARY, this consortium, the Partnership for Excellence in Education, Research and Innovation in Biofilm Antibiotic Resistance. And of course the RESISPART, this particular consortium between Norway, India, Brazil, Canada, and US. This is consortium led by University of Oslo. This partnership will undoubtedly strengthen and expand collaboration in teaching, research, and development activities in the Piracicaba Dental School, and of course in the entire university, in the entire UNICAMP. It's worth emphasizing the importance that our university grants to research and innovation. In addition to more than 20,000 undergraduate students, UNICAMP has more than 26,000 postgraduate students. UNICAMP and its spin-off companies hold more than 1,200 patents. We are over 1,100 professors and 7,000 technical administrative workers. A significant portion of them are also researchers with notable scientific, bibliographical, and innovative production. So we strengthen this participation of both teachers and technical administrative workers in research and innovation. At the beginning of this year, 2022, primarily due to the favorable ecosystem for innovation present in our institution, as well as the outstanding articulation of the areas in infectious disease, my area, and the public health, the existing infrastructure and strength of the university in research, innovation, and dissemination in the biomedical area, as well as the importance of consolidated different interdisciplinary skills, UNICAMP implemented a global health hub. The UNICAMP Global Health Hub brings together professors from different institutes, such as Institute of Biology, Chemistry, Institute of Mathematics, Statistics, and Scientific Computing, Institute of Philosophy and Human Sciences, the School of Medical Sciences, where I'm from, and the University Hospital. These units are linked by interconnected areas such as basic experiments, laboratory research, innovation and technological development, clinical epidemiology and health surveillance, clinical and experimental immunology, emerging infectious diseases, new drugs for neglected diseases, chronic non-communicable diseases, conduction of clinical trials, bioinformatics and mathematical modeling, mental health, demographics, inclusion of vulnerable populations, education and professional training, and of course, antimicrobial resistance, which I am the leader. In the hospital setting, we are quite concerned about the NDM and KPC carbapenemase producers gram-negative bacilli, methicillin-resistant Staphylococcus aureus, vancomycin-resistant enterococci, and other multi-drug-resistant organisms. Recently, outbreaks of Candida auris were detected in some Brazilian hospitals, which is of special attention. Azole-resistant Aspergillus fumigatus, especially in immunocompromised individuals, is another risk for human health. Through international public-private partnerships, we are implementing a new Level 3 biosafety laboratory. We have already implemented a laboratory for CRISPR-Cas9 gene editing to study the resistance of Aspergillus fumigatus to azole antifungals and fungicides. Currently, we have ongoing research based on citizen science, with collaborative activities in 20 laboratories in almost 1,500 citizens among 12 countries in Latin America: Argentina, Brazil, Chile, Colombia, Costa Rica, Ecuador, Guatemala, Mexico, Paraguay, Peru, Uruguay, and Venezuela. It's essential to highlight the role that agribusiness plays in the economy of many Latin American countries, especially in Brazil. Through phylogenetic analysis and georeferencing, we want to determine if there is a correlation between areas with extensive use of fungicides and the presence of resistance to azoles, fungicides, and mutations in the CYP51A gene of Aspergillus fumigatus. In this sense, the World Antimicrobial Awareness Week is crucial to raise awareness of the rational use of antimicrobials in medical practice, of course, but also in the agriculture and livestock, and encourage best practices among the public, stakeholders, and policymakers in a global health perspective. I want to thank you once again for the opportunity to show Unicamp's commitment to science, research, development, and innovation. And furthermore, and finally, on behalf of Professor Maria Luisa Moretti, I thank the Research Council of Norway for funding, through the INTERPART program, the Partnership for Excellence in Education, Research, and Innovation in Biofilm and Antibiotic Resistance. Congratulations, Professor Antonio Pedro and the Piracicaba Dental School for this agreement signed with the University of Oslo and the other universities part of this partnership. Thank you very much for your attention.
Professor? Okay. Thank you very much, Professor. Thank you. Congratulations. Thank you, Professor Plinio. I think that it's very good to hear that Unicamp is very in this research and the commitments together about the research and education, and I think the antibiotic resistance is a theme that is not only like for us, just as a global problem, and I think that Unicamp probably it has his part in discussing and producing new research and technologies about that. Okay, thank you very much. And about next, I'm very happy to have here Professor Alex Young Vick. She's professor of the Department of Cardiology and Gerontology at the University of Oslo. We are very happy because when we say about the project, we are not just trying to produce research, we are trying also to keep the education and to have like a very good quality of research, of education. So the commitments that we have, it goes further from the research area. So I think Professor Alex is going to tell you a little bit more about her visit here in Brazil, and we are very happy to have you here, Professor. So please be welcome.
Good morning, everyone. I'd like to start by thanking Fernanda Pettersson very much for inviting me to be part of this very special meeting. It's my first time in Piracicaba, but not my first time in Brazil. And I would like to tell you a little bit about the University of Oslo, and more specifically, the Faculty of Dentistry. We have two dental students in their 4th year that will be coming to visit the dental school here in March for 3 months. And we really, really hope that soon we will also have some students from here coming to visit us. I would like to start by showing a small video from the Dean of the Dental Faculty. That's Tiril Wilhelmsen. She has made a small video to show you. So it's just a short one, and then I will say a few words and show you some information about the University of Oslo.
The Dean at the Dental Faculty in Oslo. Antimicrobial resistance is happening. My name is Tiril Wilhelmsen, and I'm the Dean at the Dental Faculty in Oslo. Antimicrobial resistance is happening right now. It's one of the biggest threats to global health, food security, and development. It is of particular concern to dental teams, as antibiotics are the class of drugs most prescribed by dentists. And as a university, we have the responsibility to educate professionals that will be equipped to meet this global challenge. Norway has had a key leading role in global agreements to reduce unnecessary use of antibiotics. For instance, the National Dental Association in Norway have issued national antibiotic treatment guidelines for antibiotic use in dentistry. Researchers at the dental faculty at the University of Oslo had an important role in this work. Clinical practice patterns are difficult to change, and that makes undergraduate education so important. Our work is just starting. Projects like RESINFORCE is important and have our full support. I wish you all a very successful symposium. I hope that this event will generate new ideas, make new collaborations, and exchange of activities. Good luck.
So, as Professor Pedro mentioned, I'm a professor and head of the Department of Caryology and Gerodontology at the Dental Faculty in Oslo. But I would like to tell you a little bit more general about our university. It's the first university established in Norway in 1811. It consists of 8 faculties and 2 museums. And we have 9 centers of excellence related to research, 9 related to excellence in education initiatives, and 2 centers of research-based innovation. There are approximately 7,000 employees and 26,000 students, and this is the numbers from 2020. I don't think have changed so much. We are very proud that there are 5 Nobel Prize winners from our university, And just when I checked on the Times Higher Education World University ranking, we're at number 1 in Norway and 126 in the world. So you can see a view of the organization, and at the bottom all the faculties, and one of them is the Faculty of Dentistry. So the University of Oslo is a research-intensive and a comprehensive university with these professional studies you can see on this side here, including odontology, but quite a few different professional programs, as well as many, many disciplinary studies. Here you can see our current rector. His name is Svein Stølen, and he's presenting the PhDs with their graduation certificates. And then some other views from around the university. We have several campuses, and there's the one in the city center is the original part of the university with very nice old buildings. You can see this one here. This is the University Hall with a nicely lit up in the late afternoon. Here you can see the same hall with many students meeting on their first day at the university, where the head of the university, the rector, and all the deans of the different faculties meet and welcome all the students. This is a view from inside this hall. It's a beautiful hall. We're very proud of this hall. It has large wall paintings made by the famous Norwegian painter Edvard Munch, and they are truly very impressive. So it's wonderful to sit here. There are many concerts held there, large meetings, and it's a very nice place to meet. This is inside the building next door where there are thesis defenses held and other meetings, and I actually had my thesis defense here. So it's very nice. And the law faculty is located on this campus in the center of the city. The largest part of the university is located at Blindern. It's a few kilometers from the center of the city, but easily reached by public transport. And here are some views from around the campus. It's a very nice campus. This is mostly summertime photos. We have a very nice, large building here housing the main library, but also nice auditorium for meetings. This is how it looks like inside the main entrance area of this building. And these are from some of the other faculty buildings on the campus. It's not moving on. Okay, I mentioned there are two museums. One of them is the Historical Museum. You can see from the website, and also a picture showing the Viking Ship Museum. The Vikings are an important part of the Norwegian history. They are very well visited. This is a yearly visited levels. And they are also very excited to have planning a new museum to house all the Viking ships and other parts of the cultural from that time in Norway. And of course, the museums are important for both research and dissemination, and they cooperate with schools. Next. The other museum is the Museum of Natural History, and there you have geological and zoological museums. And more recently, they have built a climate house with obviously focus on changing climate, and have lots of interesting presentations there. And it's also very well visited. So these are quite important museums for the university to get income from visitors. The botanical gardens are located next to these Natural History Museum area.
Tem alguma coisa bonita pra caralho aqui. Não é tudo nada. Matar o som do computador. Não tem mais som lá. Não vou fechar. Fica essa merda. Não, nada não.
Licença. Então, dando feedback que o som está parecendo um secador de cabelo.
Tirar o meu. Não tiro o meu do DS. Não quero falar de som.
At the faculty. With regard to students, we have about 60 dental hygiene students. It's a 3-year bachelor course at any one time. We have about 310 dental students. It's a 5-year master degree, like here. Approximately 50 specialist students, specialty candidates at any one time, and approximately 50 PhD and postdoctoral students. And here is a picture of the wall of the Institute of Oral Biology. Unfortunately, it's not located close to the other part of the faculty, so it's about 3 kilometers away. And it's close to the Norwegian National Hospital. So there's quite a lot of collaboration between the institute there and part of the medical faculty located there. I mentioned the Preclinical Simulation Center that's located right next to the Institute of Oral Biology. Here you can see some photos from the simulation units. We have 44. So the students are usually divided into 2 groups, so one group is here at a time and they swap. So this is an overview of the master in dentistry. The first 2 years are preclinical years, and some of that, at least one and a bit year, is partly in collaboration with the medical faculty. So the dental students and the medical students start together, as well as students doing nutrition studies. And then the 3rd, 4th, and 5th year are preclinical, and then more and more clinical. So the last 2 years are purely clinical, whereas the 3rd year is a combination of preclinical simulation training and preclinical studies, and then they start in the clinic the last part of the 3rd year. It's called an integrated master because they have a thesis that they must make and present at the end of their studies. We also have this Bachelor in Dental Hygiene, where they have a 3-year course, as you can see here, with introduction, and it's very related to public health work. And they also have a thesis in their 3rd year. So in the Institute of Clinical Dentistry, we have 3 clinics, one for adult oral health care, one for child oral health care, and one for specialist training. And then we have the oral health laboratory. Can you press once more? Thank you. Oral research laboratory, I'm sorry. They do a lot of work and have a lot of activity as well, like the Institute of Oral Biology, with a lot of students coming in to work there as part of their PhD program from around different countries in Europe. These are the 3-year specialty programs here. And then the oral surgery and oral medicine is a 5-year program. And these are the faculty departments. Yes, I won't read them all up. So this is probably the most interesting one. We have exchange programs. We have many partners under the Erasmus program. It's a European Union program for student exchange. So a lot of our students travel and visit, spend some time in these different dental schools, and we receive students from those schools. And we have a 3-month period in the spring, so from March to May, where all our teaching is in English, so that the students can follow the theoretical teaching also. And there's another program, it's called, it's called Nord Plus, this one here, and it's specifically for the dental hygiene students. So they can choose between Sweden and Denmark. So those were our 2 students visiting in Trinity. Okay, the other programs, the bilateral student exchange programs, and they're for South Africa and Tanzania, and then here. So we're very happy to have this one now, and we should have had students coming here in 2020, but then it got cancelled, and they were very sad. So we have 2 students that are really looking forward to come, as I said. You can see students visiting our clinics from other countries, and 4 of our students in Cape Town, which is actually the most popular place to visit so far. We see if Brazil can take over that spot. Regarding research, I won't say a lot about that. We have a Vice Dean of Research, and she would be able to tell you more, but this is the main research topics across here. I'm actually involved in this dry mouth research, so we have a dry mouth clinic, but there are, you can see this one, which is very important here today. Sorry, that went too fast because Pedro is pressing on me. So this is just to wish you all welcome to the faculty in Oslo, and thank you very much for having me here.
Bom dia, good morning. It's my pleasure to introduce the next speaker, Professor Ulf Dahl. His background is in the laboratory-based research on the epidemiology of tuberculosis and antimicrobial resistance, and currently he is the specialist director at the Norwegian Institute of Public Health, NIPH, and heads the NIPH Research Center in the antimicrobial resistance. He's a great scientist. I know that from his work and the kind of work he's carrying on in these areas in the antimicrobial resistance, and he's a wonderful mentor for the young researchers and students. With this introduction, I'll welcome Ulf for his presentation. Thank you.
Thank you very much, Sharmila. Oh, great, great. There we go. I'm going to talk to you a little bit about the Norwegian action plan of, against AMR and the results we have obtained over the last few years. And I will also mention to you what plans we have for the future, or what we are expecting for the next period. But first, as Professor Trabasso mentioned, today is the beginning of the World Antibiotic Awareness Week that the WHO has initiated, and there are many activities going on in numerous countries around the world, all related to bringing the attention to antibiotics and other antimicrobials. So that is a great day to have a symposium like this. We know that in many countries around the world, it's possible to buy antibiotics over the counter or through the internet without a prescription. And these are examples of absence of policy. We have also known over the past decades, or even since the beginning of the antibiotic era, that the usage of antibiotics has increased in many countries and continuously over the decades. As seen on the right here, the countries that had measured increase in antibiotics in the period year 2000 to 2015 are marked in red. And then on the right side, we see, or on the other graph on the left side, we see how the increase in antimicrobial resistant infections increased during the same period. And these numbers are from China, but we have seen similar developments in most countries around the world. This led this woman, Dame Sally Davies, which is the chief medical officer in the UK, to put antimicrobial resistance up on the national risk register right there together with international terrorism and climate change. By doing that, she brought antimicrobial resistance on the political agenda, and this was also part of the reason why the WHO launched their Global Action Plan against AMR in 2015. The Global Action Plan was the fundament for all the various national action plans that followed. The USA, Brazil, Norway were early starters coming up with these national action plans, and now today more than 100 countries around the world has their own national action plans against AMR. So what is an action plan against AMR? I'm going to take you through that, and I will also show you how it has functioned in Norway. But first, an action plan in Norway has been anchored in 4 different ministries. So it's a very wide political support for this. It's the Ministry of Health and Care Services. It's the Ministry of Agriculture and Food. It's also the Ministry of Trade, Industry and Fisheries, as well as the Ministry of Climate and Environment. And for the next action plan that I will get back to at the end, we also have the Ministry of Foreign Affairs on the agenda. So it's a very broad political support for these action plans. The human side of the action plan, the human medicine side, has a big steering committee that are representatives of various expert institutions. They are directorates. It includes my institute, the Norwegian Institute of Public Health. It includes various healthcare institutions like the major hospitals. It also includes the associations like the Medical Association and the Dental Association. So everybody has an ownership to this. Everybody feels responsible for the activities, which is important to ensure coherence and that people participate actively. The Norwegian Action Plan 2015 to 2020, it was extended till the end of 2022, so it's still active. It had a very ambitious goal. It said that Norway shall enhance appropriate use of antibiotics, including more narrow-spectrum antibiotics and less broad-spectrum. That was one important target. The other was that Norway should be among the 3 countries in the world that use the less antibiotics, and that we should contribute to ensuring international access and collaboration access to collaboration and research on the field. We were also concerned that there are many challenges related to getting access to antibiotics. So AMR, antimicrobial resistance, is one challenge, but there is another side to that medal, which is actually a larger challenge to public health in many countries, that people that need antibiotics do not get access to them, which is also a target for our international work on the field. And then we also wanted to contribute to improving diagnostics and surveillance and analysis of these data in many countries. So these are hairy targets, and I will see how did we organize us to do this, to reach these targets. First, on the organizational, do I have a pointer? Yeah. First, on the organizational side, we placed responsibility in someone's hands. We made it clear that county municipals and county governors and municipals were responsible for ensuring all these activities. And we also strengthened various research, various competence centers. Like we have competence centers for specialist healthcare services, and we have competence centers for primary healthcare services. They were strengthened to be able to support the AMR issues that were launched. So placing the responsibility and organizing the national activities through these organizational changes. On the, I wonder if I should. Can I go down a bit so I can see these slides better? Do you mind, Pedro, if I stand here? Thanks. And then to the general population, we also had many activities. It was largely information campaigns, informing people about antibiotics. You shouldn't always take it. You shouldn't force your physician to prescribe them. We had targets to keep a very high level of immunization in the child immunization program. We developed a immunization program for adults, which was actually a great help when a few years later everybody lined up to get their COVID-19 vaccines. We also had activities to try to make the manufacturers make more appropriate sizes of antibiotic packages, which we failed. But where we did succeed was to introduce validity dates for antibiotic prescriptions. So if they're not bought immediately, the patient cannot keep that prescription for a few weeks or months and go back to it later. Within the primary healthcare services, we developed peer review processes where each prescriber gets data on how your prescription practices are, and you could compare yourself to that of colleagues to see how you're doing compared to those you want to compare yourself to. We also developed these systems that whenever you do an electronic prescription of an antibiotic, there comes up a warning image on your screen that says, are you really sure you're going to prescribe this? Do you really need to? Like some examples. We got diagnostic codes on all prescriptions of antibiotics. Within the specialist healthcare services, we also had activities which was largely related to stewardship programs, where you have an individual or a group of individuals that have the assignment of keeping an eye and keeping information about antibiotics, so that they review the prescription practices of each department, of each individual prescriber, and they have discussions and are available for advice. In addition, we also launched a system which ensures that we have regular updates of guidelines for how to prescribe antibiotics. Similar activities also in the municipal healthcare services, where we have nursing homes. That is a big producer or big consumer of antibiotics. And there also we had activities to make sure that this is always on the agenda, that every time you prescribe antibiotics, it's within the reasonable guidelines, and that everyone is comfortable with what they prescribe. And on the dental health side, as Alex just mentioned, there was also assigned a committee that are taking care of guidelines directly for dentists. All this is part of an action plan in Norway. Oh, thank you. But do they work? That is the question. Are they just fancy words and speeches? Well, I'm going to show you a few examples how we can use the various registries we have in Norway to measure. And we see that all through 2019, all pharmacies in Norway, it was rather stable. That's everything that is sold in Norway. Everything goes through one national importer, and that sells to all the different pharmacies in Norway. It's very stable. But in 2020, something happened. There was a peak here in March 2020. This was the month of the lockdown, when the pandemic had reached Norway, and Norway decided to lock down as well. But there had been a pandemic declared already for 2 months. So we were not sure, were these numbers due to consumption, or was it only that the pharmacies were hoarding, that they were buying to be ready for a pandemic? And we can also see that in the following months, they didn't buy as much as usual. It was a much, much lower sale of antibiotics to Norwegian pharmacies. So that's why we have another, oh thank God, then we have another registry, which is the prescription registry. And this is the registry that shows what patients buy from Norwegian pharmacies. And here we can see that the peak in March 2020, it's not there. Actually, it's lower in March 2020 than it was in March 2019. And we also see that it is very low in the following months. So the peak in March 2020 was due to pharmacies buying but not selling antibiotics. And we also see that there was a very low grade of antibiotics consumption in Norway during the first months of the pandemic, and that can have been due to two things. One is that we were all at home, we didn't go out, we didn't get affected, we had kept social distancing, so actually we weren't sick. But it could also be that we didn't go to the doctors, because that was discouraged. You should do that online, and that we do not really know. But what we do know from other registries is that the rate of infections did not increase. In fact, a lot of the resistant infections were reduced during the pandemic. Our target in the 2015 to 2022 action plan was to reduce the usage of systemic antibiotics with 30% by the end of the period, which means, and it should be compared to the numbers from 2012, so that we should use, in the end of this action plan period, we should use 30% less systemic antibiotics than we did in 2012. That goal was not reached. It's the gray bars, and this is the goal bar that we should have reached. And we see that we didn't really get there, and we're not even getting there in 2022. It seems now that it's going a little bit up again. But we did reduce the amount of systemic antibiotics, which is largely prescribed in hospitals, to patients in hospitals, which means that these numbers up here, maybe they were unnecessary, because we also can document that people did not get more sick or did not, this was not a risk behavior treatment, not to give them antibiotics like we used to. The other goal was that we should reduce the antimicrobials used for respiratory infections, which means those that go to the doctor, get their prescription, take their antibiotics, but they live at home. They are not in the healthcare services. That goal was reached very quickly in the action plan period, and it's continued to go down. And this is also the area where we do suspect that there is more unnecessary use than within the specialist healthcare services. We also had many activities on non-human side, like within the veterinary medicine and in agriculture, in the environmental fields. But just to take a very, very few of them, Norway is the only country, as far as we are aware of, that has an ambition and has so far managed to keep MRSA infections out of the swine production field. We also managed during this action plan period to reduce the amount of ESBL infections in the poultry industry, which is largely chicken. We have a little bit of turkey industry in Norway. And that we have also reduced the use of antibiotics both in food industry, animal industry, as well as in pets. So what are the new areas now? The current action plan is coming to an end. Our ministry is already giving orders and expecting help to produce the next action plan, but it's not in place yet. So these areas that we believe will be important for the coming period, that's one issue we expect will be focused on later. When it comes to the carrier studying, we do not really know how many of us are carrying resistant bacteria of healthy people. We only know amongst those who get sick. And if we are going to monitor the effects of public health activities, we need to know if it has an effect on the majority of the population, which is the healthy ones. So carrier studies is important. We also don't know what is really the burden of resistant infections in our society. We do know that some people are sick and we know them are in the hospital, but we're never really sure what is due to resistant infections or just the infection in itself. So the burden of disease due to AMR is probably also important to clarify. We have a unique opportunity now after the pandemic to really evaluate the effect of infectious prevention and control, all the measures that we initiated during the pandemic, that we could use to see which ones are effective, which ones are the ones we should probably try to stimulate for future use. And the same we could also say about travel. If we're going to give very sound travel advice to people, it's a good period to check during the pandemic when people did not travel much, because we have a control side there. New healthcare services are always developed. And today there are millions of services offered. Many of them depend on antibiotics, and they are introduced without ever really seeing the consequence for need of more antibiotics and use of antibiotics in healthcare services. And everything related to One Health is also on the agenda. One Health meaning that humans, animals, environment share the same microbes, and to study these and to find activities to reduce the burden, we need to look at everything as a whole, which is what they call One Health. But One Health needs to be defined. It's not sufficient to just say we look at everything. We can't do that. So we need to know what is really the use in animals and in agriculture. How does the microbe spread between humans and animals, and between animals and the environment? We need to identify that. We need to define which agents are relevant. We know that Campylobacter and Salmonella are important, that infect animals and humans alike. We know that Mycobacteria and Neisseria doesn't. But then we have a lot of agents in between, like E. coli and Klebsiella. We know that they can, but we're not really sure which ones, and are there different species, are there different targets? We need to identify that and not start searching for anything that could potentially spread. We don't know if One Health challenges are the same in cities as in the countryside. We don't know if they are the same in polar areas, in temperate areas, or in tropical areas. And we don't really know the source of the impact of water and sewers in these relations either. So there are a lot of things that needs to be clarified before we can really set up proper One Health studies or surveillance. At the very end, I'm just going to mention one other action plan because it's so importantly intertwined with AMR. And in Norway, 3 years ago, we launched an action plan for improved infectious prevention and control in the healthcare services. And the target was, or the aim was to reduce the healthcare-associated infections, which we call HIEs, and also to improve the organization and structure of IPC in the healthcare services. This action plan bases itself or focuses a lot on essential infection prevention and control. And essential infection prevention and control, when you ask people about that, we all would think about hand hygiene and face masks like we are using now. But essential infection prevention and control, it's much, much more. It is also things that we don't really think about every day. It's the cough etiquette. It's how we place patients in hospitals when we have isolations and we have the storage rooms for where we have the equipment. Is it close to the patients? Do we need to carry it around? It's also about how we clean our departments and hospitals, and it's how we dispose of litter. It's also related to how we handle linens and towels and how we have routines for injections. It's how our routines for disinfection is, and it's also about all the prevention of injuries, etc. All this is essential, infection prevention and control. But there are not clear, it's not clear who is in charge of this, who is responsible. Of course, we have leaderships, but who is responsible for following up and making sure that everyone is calibrated? And to do this more general than I went through the action plan on AMR, also here we had organizational clarifications, that the ministry was very clear that various county governors and municipals are responsible for having proper programs for this. We also made national responsibilities for keeping overviews, complete registries of where we have isolation facilities in the healthcare services. And also in the healthcare facilities, it was given a lot of assignments where they have to go to root cause analysis when they have cases of high, that they identify why, and that they have a list of check marks that we can provide for their help. We also make them write their cleaning procedures so that it's all documented, and so on with other issues. On the national level, we make clear guidelines for everything from hand hygiene to IPC in general practices. Plus that we established a field epidemiologic group that can support local hospitals or regional hospitals when they need, if they have challenges related to high in a setting. We even made regulations for how to build new healthcare facilities with IPC as a focus. On the academic side, we also included IPC education in the various healthcare professions, and we suggested that the universities get an academic IPC position and other activities. The fun thing about this was that now, earlier this year, the World Health Organization has also launched a global strategy on IPC, inspired by the Norwegian one. That was what I was planning to say, and I'll give the mic back to Sharmila. That I believe, yes. Thank you. I think you should give me a gift.
Okay. Thank you for the wonderful lecture.
So good morning, everyone. I would like to welcome to the stage Claudio Nishizawa. His background is in pharmacy and biochemistry, and he's a specialist in health, in public health and health surveillance. Currently, he is a coordinator of strategic health regulatory actions at the National Health Surveillance Agency, and he here to present the National Health Regulatory Action Plan on antimicrobial resistance. So, Claudio, the stage is yours.
pegar o conector lá. Hello, good morning. My name is Claudio Nishizawa. I'm the coordinator of Officers Translation Health Regulatory Actions. Ah, é, tá certo. Não, não, acho que tá bom aqui. Sorry. Good morning. My name is Claudio Nishizawa. I'm the coordinator of the Office of Strategic Health Regulatory Actions at National Health Surveillance Agency. Our agency is a federal government, and it's linked to the Ministry of Health. It's a pleasure to be here and to share information of our national plan with you and to be here in Piracicaba. I would like to thank you for the invitation from Pedro and Unicamp. My office is linked to the director president, and I will show the chart in the next slides. Our regulatory agency is called Anvisa, Agência Nacional de Vigilância Sanitária, and is the Brazilian Health Regulatory Agency, and is the autarky linked to the Ministry of Health, part of the Brazilian National Health System. As the coordinator of the Brazilian Health Regulatory System, presented throughout the national territory. It was created by this law in 1999. Our mission is to protect and promote the health of population, intervening the risks associated to the production and use of products and services, subject to health regulation in coordinated and integrated action within the national health system. I will show some of the products regulated and services. This is our scope of action. We regulated pesticides, food, medicines, medical devices, cosmetics, pharmaceutical ingredients, smoke products derived from or not from tobacco, borders, pharmacy and drugstores, sanitizing products, blood, tissues, cells, organs, advanced therapy products, ports, airports, clinical trials, health education, health emergencies, and health services. These are some technical discussion groups that we are part of. The ICH, the International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use, Pharmaceutical Inspection Cooperation Scheme, International Food Safety Authorities Network, National Center for Nuclear Emergency Management, Institutional Safety Captain from the Presidency, the Secretary of Integrated Operations of Ministry of Justice. Our principles to regulate the products and services are based on the good practice, based on safety, efficacy, and quality of products and services. This is a huge map that we point our participation in the national health systems. These are our internal sections, and this includes the whole interaction with the Ministry of Health and the national health systems abroad the whole territory, Brazil. And it involves national councils and the legislation that it was established to organize the health system. This is the organization chart of our organization, and this is the directory board composed by 5 directors, including the director president. And this and our coordination is inside the director president. He is chief of cabinet. This is a larger chart that where we when we can see my coordination is here. The strategic actions is inside the National Health Surveillance Coordination Office, and it's linked to the Director President Chief. This in this scenario, when we act, is when we face new technologies, high personal interactions by the way of transportations, climate change, infections, outbreaks, rise of resistant microorganisms to antimicrobials, emergent disease and re-emergent disease. I will give some examples so far. And our activities are related to health menace detection, sharing information, technical assessment response, internal exchange to coordinate complementary actions, external exchange to coordinate complementary actions. In this scenario of infectious disease, we participate in situation room with the Ministry of Health and interaction with health services, define health assistance flow, make internal and external collaboration to coordinate complementary actions, regulate boardings, airports, regulating the flow and procedures to manage in the situation of new infectious disease scenario. Regulated diagnostic tests for these infectious diseases, manage to regulate and assess new medicines or medicines that we always have, exceptional importation, And in some scenarios, we make technical notes in specific areas to guide the whole national system how to handle in specific situations and establish a strategic plan. In Brazil, we have 3 national action plans on AMR. We have the PNBR it's coordinated by the Ministry of Health, PNBR Agro, this is from the Ministry of Agriculture and Food, and we have our PANVISA, that is the Health Regulatory Action Plan on Microbial Resistance. This is in the middle is the PNBR from the Ministry of Health, PNAGRO from the Agriculture, and in the right is our PANVISA. They are independent action plans, but they are linked together, and it's we are together to establish and complement each other. The PNBR from the Ministry of Health, it's a more global national action plan, and it was prepared according to the WHO Tripartite Alliance. And the Food and Agriculture World Organization for Animal Health, and United Nations Food and Agriculture on a global action plan on antimicrobial resistance. The PANAGRO is an action plan of the Ministry of Agriculture, and its objectives is aligned to the same objectives defined by the Tripartite Alliance. And linked to the PANAGRO, it was established a program, a national program for the prevention and control of antimicrobial resistance in agriculture called AgroPrevent. And it was established on a normative instruction 41 in 2017. And its priority was defined as phase 1 in poultry and swine pharmacy, and in phase 2, 2021 and 22, poultry, swine, and beef cattle. Our PANVISA was established by Ordinance 15721 and established the working group to evaluate and monitor the actions. And the meetings are bi-monthly ordinarily. Since 2016, it is inside the strategic plan. And main objectives, according to 5 strategic actions, axes proposed by the WHO. It's established in a 2-step approval by each director and the board of directors. Additionally, there is a strategic management committee that assesses and follow up the plan each quarter. This management committee involves all areas in the ANVISA. I'll talk about the ANVISA, the plan structure. It's a strategic plan from 2020 to 2023. And it has objective indicators and subjectivities. Some of the plan objectives in this period make society, professionals, and health management aware of antimicrobial resistance. Train professionals and managers of the system and health services on the topic of AMR. Improve the national laboratory for surveillance and monitoring AMR. Implement integrated surveillance and monitoring of AMR at a national level. Expand knowledge related to AMR through scientific studies and research. Contribute to the Ministry of Health in definition of a comprehensive infection prevention and control policy. Reduce the incidence of infections with effective prevention and control measures in health services. Improve health intervention in order to qualify the prescription and antimicrobials and reduce the use of antimicrobials without a medical prescription. Improve regulatory measures for the responsibility of health surveillance regarding the presence of antimicrobial residues in foods. Some indicators related to these 9 objectives. Develop and implement ANVISA's strategic communication plan on the topic of AMR. Develop ANVISA training plan on AMR. Work in a coordinated manner with Ministry of Health to include the theme of MR and prevention of control of HAI in technical training undergraduate and graduate curriculum professionals in the health of human health. Participate in definition of new model of national network laboratories for surveillance and monitoring of microbial resistance in human health. Guide professionals from laboratories that carry out analysis of competence of health surveillance in the new model of national network of laboratories for surveillance and monitoring of antimicrobial resistance. Perform and improve quality monitoring and antimicrobial drugs. Define and implement a model for monitoring and commercialization of antimicrobial drugs in order to support actions aimed to rational use of antimicrobials. Develop an information system for reporting and analyzing data on HII, antimicrobial resistance, and outbreaks in Brazilian hospitals. Promote actions to qualify and reported data on HAI and antimicrobial resistance. Consolidate the surveillance and monitoring system for outbreaks involving multi-drug resistance, microorganisms in health services. Structure a project for national program for monitoring resistance microorganisms and antimicrobial resistance in foods. Many of the activities is related to HAI, that is health assistance related infections that we find in health services that we regulated. Participate in the construction of intersectoral monitoring of resistance microorganisms and antimicrobial residues in food and water for human consumption, together with the Agriculture, Ministry of Health, and Ministry of Environment, and other institutions. Participate in Ministry of Health discussions on the interoperability between laboratory data information systems. Survey and prioritize studies and research needs related to AMR inclusions in the research plan. Define competences of the health systems regarding the prevention and control of health-associated infections. Articulate with Ministry of Health national actions for prevention and control of healthcare-associated infections and microbial resistant in health services. These are some examples of specific activities related to that indicators. Yes, with Ministry of Health on antimicrobial resistance communication plan, hold the workshop to identify premises, objectives, strategies, target audiences, communication channels, roadmap, and execution schedule to be adopted. Implement a strategic communication plan on the topic of AMR. Evaluate the training currently promoted by Anvisa that could on the topic of AMR. develop a curricular proposal on prevention and control of health assistance infections and microbial resistance in health services for technical training and graduation courses for professionals in areas of human health, prevent and discuss coordinating areas of the plan curricular proposal on prevention and control of health-associated infections and microbial resistance in health services for technical training and graduation courses for professionals in the areas of human health. There are many activities and some related to the control and prescription of medicines and laboratory tests and communication between laboratories. And we are integrated with the Ministry of Health laboratory network. The numbers of the plan is there is 9 objectives, 61 activities. Now it's 49 activities completed, reached the 8.32% achieved. These are some examples of investigations of microbial resistance that we found like Candida auris there in the northeast of the country, and another mycobacteria there, and other cases that we follow together with the Ministry of Health. Some challenges of the plan is top-level governance, the laboratory network that depends on the Ministry of Health, population engagement to implement the communication plan, monitoring use and consumption of antimicrobials, the training and reporting of the identification of resistance to microbials. Some perspectives of this of the plan is the One Health approach that is from World Health Organization, the United Nations, and Food Agriculture organizations of the United Nations, told yet by OF. And we are organizing this approach, and it will reinforce our plan. And this is coordinated by the Ministry of Health here in Brazil, and we think our plan will reinforce it in this approach of One Health, of 4 parties. Thank you. This is our call center, toll free. If you have any question, you can call this number. And if you have information that we are reporting, we can get through this channel here. Thank you.
Okay, thank you, Claudio, for your presentation. So here's Thank you. Now we have time for questions for all the previous presenters. How much time? Yeah, if you have some questions for Claudio and the other previous presenters, you can do it now. And we will head for coffee break for like 15 minutes and we'll come back here. So if you have questions, just raise your hand. No questions? Oh. So, have questions?
I have a question for you, Ufi. I wonder if you have any data in relation to vaccination of COVID and antibiotic prescription or decrease on that from Norway.
Yes, we have data on vaccination against COVID-19, absolutely. But we have not combined that or crossed that with the prescriptions of antibiotics. But we would be able to do that if we got ethical clearance for it. We do have personal identification numbers, so it would be possible to see if. So I guess you're thinking of a hypothesis that patients that were or people that were vaccinated against COVID-19 may have used antibiotics in a different way than non-vaccinated people.
Yeah, exactly.
Yeah. No, we haven't done that, but that should be possible. Yeah.
Okay.
Thank you for that question. You can throw me that box back. Isn't this a cool, really cool mic? So if anyone has questions, you get to receive this microphone. Okay, so then we take coffee and we'll be back here in 15 minutes. Yeah. Welcome back, everybody. I will be your moderator in this session. I have the pleasure of introducing the next speaker. She is Brasileira, merged Norwegian, and she handles her multinationality just the way she handles her multidisciplinary research. Here she is, the primus motor for this program, Professor Fernanda Petersen.
Thank you for the introduction, and thank you all for being here today to watch this symposium. So I will start emphasizing the previous speakers, Dr. Dalia, Dr. Claudio, emphasizing the urgency of this problem, antimicrobial resistance. So the message from the World Health Organization, the United Nations, is clear. There is no time to wait. We need to secure the future from drug-resistant infections. So I'll show you now one of the most comprehensive studies with estimates of the problem of antimicrobial resistance at the moment. And it was this study published in the Lancet, systematic analysis, so that had data for more than 200 countries on antimicrobial resistance in 2019. And so in this study, they showed that antimicrobial resistance has 5 million deaths in 2019, associated with antimicrobial resistance, plus 1.3 million deaths directly caused by antimicrobial resistance. So we are talking here about a silent pandemic. So the main drivers of the crisis we are living now, one of the main drivers is the overuse and misuse of antibiotics, but even use of antibiotics as well. And in this, one of the fields that are receiving increasing attention at the moment, it's the human microbiome. Are there clues there to fight antimicrobial resistance? So that will be then the topic of my presentation, the antibiotic collateral effects on the human microbiome. Does it matter? So let's have a look first about this really interesting characteristic of the microbiomes, which is the landscape of antibiotic resistance genes, known as the resistome. So 2013 marked the start of the studies looking at antibiotic resistance in this comprehensive way using metagenomics. So with metagenomics, you can look at the entire genomic content of your microbial community. And this study, it was really interesting. So it showed an amazing amount of antibiotic resistance genes that you can find in the microbiomes. In some individuals, more than 1% of the genes in the microbiota are resistance genes. And it showed also, if you look here, there was data for China, Denmark, Spain, that China had the highest abundance of antimicrobial resistance genes in the microbiome, and more than Denmark, which is a country where the use of antibiotics is quite relatively more restricted. And you see here Spain, that again has a higher number than you would find in Denmark. So in the Nordic countries, in general, there's not much use of antibiotics compared with other countries. Then it came, I'll show you another super exciting study that was done with an uncontacted tribe in the Venezuela area. So the microbiome of uncontacted Amerindians, where this same kind of technique showed the presence of various antibiotic resistance genes, including resistance to synthetic antibiotics. So they found resistance to third, fourth generation cephalosporins. And what this is telling us is that bacteria, they have been equipped to fight back antibiotics far before the discovery of antibiotics. Is that a surprise? Not really, given the fact that most antibiotics we use, they have their origin in bacteria and fungi. So antibiotics are in nature. But what is indisputable is that the amount of antibiotics produced in nature cannot be compared to the massive amounts of antibiotics that have been introduced by humans. And you can see in this figure here, you have here the penicillin resistance in Streptococcus pneumonia, and you have total antibiotic use. And you see that countries where there is a high use of antibiotics, you have here Spain, France, they also have a high proportion of resistance in these bacteria. So there is a clear correlation between resistance and antibiotic use. So let's have a look now. We are talking about if it matters, this encounter with of antibiotics with the microbiome. So let's have a look then first of how this encounter is. So there are several factors that will influence this contact of antibiotics with bacteria. We can cite, for example, the pharmacokinetic and pharmacodynamic properties of the antibiotics. You have, for instance, metronidazole, which is very much used by dentists, so that you get high concentrations in saliva, almost the same as you would get in blood. And you have antibiotics like amoxicillin, which it's probably the antibiotic we use mostly in dentistry and in all other areas. And with amoxicillin, you would have high concentration in blood, very low in saliva, at least in young individuals. When they get older, then things change. Then you have other factors like the dose that you are using, the route of administration, the treatment duration, and the concentration of antibiotics we are using. It's usually high concentration, so we are trying to eliminate the target microorganism, and we are working, we try to work in an area here where the likelihood of resistance is low. But what is inevitable is that the microbiome will be exposed also to these antibiotics. And what does it happen there? The antibiotics that will be reaching our microbiota, the gut microbiota, the oral microbiota, and the vaginal and whatever, you are going to get gradients of antibiotics that are usually in this zone here where the likelihood of resistance is higher. And what you are going to have, you have different bacteria there, different species. They respond differently to antibiotics. So for some of them, the concentration that will be there is going to kill them. For others, it will not. It may have some other effects. And what this all leads to, it's a total chaos, ecological chaos. And it can favor resistance. Does it matter? And to answer this question, one important consideration is what do we have in our microbiomes? What is there? And although many people don't think about that, there are many pathogens that we are carrying, healthy people are carrying. And I will give you some important examples. So here I have listed major pathogens in the human microbiome. Here you have the oral cavity and pharynx. You have the gut. And you have, I'll give you an example here, Streptococcus pneumonia. 25% of us, the adults, are carrying Streptococcus pneumonia in a healthy state. So Streptococcus pneumonia kills more than 1 million people every year. Another example here, let's see Haemophilus influenza. 75% of us carry Haemophilus influenza. So it causes severe infections in 8 million people every year, and it kills another 1.4 million. And then you have Klebsiella pneumonia, which is a big problem now in relation to antibiotic resistance. 10%, or depend on the population, 30, 40% of the population, the adults are carrying Klebsiella pneumonia. So Klebsiella pneumonia has become, there are some Klebsiella pneumonia that are so resistant that they are not responding to antibiotics like carbapenems, which are usually last resort antibiotics for gram-negative infections. I'll show you a beautiful study done by the Harvard Public Health Institute, Public Health School, where they did a study that was published in PNAS that showed that these bacteria that have the arrow here, which are 4 of the 6 main killers, drug-resistant killers, most of the time, 8 to 90% of the time that they are being exposed to antibiotics, it's not because they are causing infections. So it's exposure to antibiotics being used for other conditions, which may not be even important. So there may be lots of things happening here in our microbiome that we don't know that is pressuring antimicrobial resistance to increase. Let's have a look now at resistance following antibiotic therapy. So what do we really know about that in relation to the carriage of these pathogens? So this year it's a systematic review and meta-analysis that came in 2018, I think. And the conclusion here is that long-term data for carriage of resistance is unfortunately lacking. We don't know much. But for 3 pathogens, they were able to extract strong data. And what this showed, I selected here Streptococcus pneumonia. And you see here you have penicillin exposure. You see here a 4-time fold increase in resistance following antibiotic therapy, and then a drop after 1 month, but not to the baseline status. So there is still kind of a 2 times increase here. And then with cephalosporin, you see the same tendency here. And for macrolide, it even came a different curve that resistance kept increasing up to 3 months. So this is a solid data. We don't have much more than this, really. So then one question is what do we know about prior antibiotic exposure at off-target sites and the risk for resistant infections? We need more data about this. But I will show you an interesting study about urinary tract infection. And what you see here, here you had women with urinary tract infection where they collected the information about previous exposure to antibiotics, and they found out that those that had ampicillin-resistant infections, the likelihood that for having been treated for a respiratory tract infection prior was 2 to 4 times more. So they are being treated for a respiratory infection, and then months after it appears that they are developing a urinary infection caused by E. coli, which is another bacteria not related to the respiratory infection and with resistance. I hope I have convinced you now that we should be looking at microbiomes. There is important information there. And now I move to these to metagenomic studies looking at the antibiotic impact on the microbiome. And here we give you some examples of our own research. So with metagenomics, we can really look at antimicrobial resistance to a level that was impossible just a few years ago. So I have divided in adults in early age. And this division is that adults, they have a microbiome that is established, more stable. And then we expected to have less disturbance there. So we were lucky here. We had a great opportunity to study the long-term effect of antibiotics. So there was a study in Norway that was being done, a multi-center study, beautiful design. So it was a double-blinded study, randomized. It has been published in BMJ, where the patients were being treated with amoxicillin, 3 months, 750 milligrams, three times a day. And they were being treated for chronic low back pain with changes on MR. And this is a treatment that is being done in Norway and many other countries. You have clinics that are specialized in this kind of pain that are using this kind of treatment. Why are they using this treatment? It's because it's hypothesized that you may have this chronic back pain because of an infection in the vertebrae caused by Coutinobacteria. Propionibacteria acnes. So the main study, the big study, it was about is this helping with their pain? So that was the main aim. And we contacted them and we got samples then that we could examine to see what is this treatment doing to their microbiome. So we collected samples from the mouth and the fecal samples, and I will present you the results for the fecal samples today, that the analysis is more complete. So what we found out, this is the amoxicillin group, this is the placebo group. So we saw an increase in the abundance of resistance genes after the 3 months treatment. And what was especially important is that this increase persisted for 1 year. And in the placebo group, we didn't observe significant changes. And the changes we observed, they were mostly for resistance against beta-lactam antibiotics, which is the antibiotic the patients were being treated with, the amoxicillin. And just have a look here. It's the different patients in this heat map. Here you have the resistance genes on the right, and then you have the results for baseline, 3 months, and 1 year for each patient. So just by looking at this quickly, you see that there is a great individual variation on which antibiotic resistance. So there was only one antibiotic resistance gene that was present in all of them. And you also see that if you look at this here, these were resistance genes that appeared only after the 3 months, for instance. There were other antibiotic resistance genes that many of them that were there already, and they increased in abundance after the treatment. So what is this telling us? So this is showing us the relevance of individual difference prior to antibiotic exposure. That may be of significance if you think we cannot use that at the moment as a diagnostic. So there are many things in the methodology that we had to work with, but it's pointing to us to a future, maybe with personalized therapies, that the antibiotics that are being given or other therapies to the different people will be based on what you are carrying before the antibiotic therapy starts. Now the super exciting, which is early age, what happens to infants that don't have yet established microbiome, so they are much more vulnerable. So early age, so we are doing, I'm conducting different experiments, different projects, where we are looking at preterm infants, actually in a project that is a collaboration with our Indian partners as well. And I wanted to show you some of we received some samples from India, to show you some results for a triplet that I think it's quite interesting. No, we are not going to, 1 second. So with early age, so there is an immense microbiome and environmental changes on the babes. And previous studies have shown that the antibiotic has a large impact in the gut microbiome. So there is an extreme enrichment of antibiotic resistance genes in the gut and the enrichment of multi-drug resistant pathogens. And this has been referred like scars, that the antibiotics are leading to scars in the microbiome of these babes. My point here is that they are looking. There are a lot of not a lot, but the few studies that we have in this field, it's gut. They are looking at fecal samples, and but there are other sites that we should be looking as well. Respiratory infections, it's a main problem in infants. But we have very few studies looking at the impact of antibiotics there. And that is what we are, one of our aims here, it's to look at the respiratory tract. Why don't we have more studies here? Everything is being done in the gut microbiome. So there are different reasons. But one main reason is that it's very difficult to get sufficient microbial DNA from these samples. So number one, there is very low microbial biomass, and number two, the main one, there's a lot of human DNA, like more than 90% it's human DNA. So you have to get rid of that. So we have used, now we got a good method, but we used more than 6 months trying to find a methodology for that. So we are getting approximately 70% of the samples of preterm babes that can go on for metagenomic analysis. And now we come to the triplets that I talked about. So here you had this monozygotic girl, so it was 2 girls and 1 boy. The samples were from day 7 of life, day 16 and day 21, and you are looking here at the different look at the amount of resistance genes. These were the ones that were most prevalent on these samples, the top ones. So I have highlighted that there's a red circle here. These are antibiotics that are considered high risk. Why are they high risk? So not all antibiotics have the same risk. So one, it's in mobile elements, so it means it can move from one bacteria to the other and spread resistance. Number two, it's found in pathogens that are important and are in this priority list set by the World Health Organization. So here we have one for Staphylococcus aureus and these two here that are very common in Klebsiella and the others similar bacteria. And you see here that although they are genetically almost identical, so they are monozygotic, you have a great difference, really. Look at here, day 16. So there is much more than genetics to this. And they are just starting their life. So I want to show you something that is really worrisome. So the relevance of individual difference, and I want to show you, we are also doing phenotypic studies to see, to find really if they are resistant or not. So we are taking some isolates. And here it's the antibiotic susceptibility for some isolates here, Klebsiella pneumonia. And here I want you to look at the R's. So resistance to an enormous amount of antibiotics. You have carbapenem antibiotic here, last resort. You have other antibiotics that are in the reserve list by the World Health Organization. That are antibiotics that are usually you need as a last resort. So these are babies, their first days of life, that's what they are carrying. So now a bit of hope that this knowledge is going to be translated into something that is going to help. Here it's a study that we are doing that is what we are targeting here is microbiome modulation. So we are trying Hamlet. I don't know if you have heard about Hamlet. It's a substance that is found in human milk. And it was discovered by a collaborator that we have in Sweden. It's being used for cancer treatment as well. It's in a clinical trial. But in bacteria, this compound induces depolarization, at least in 7 of the World Health Organization drug-resistant priority list pathogens. And what we are finding out, we are using a model of microbiome here, and what we are finding out, this here is the control. It's a microbial community that we are growing in the laboratory. This is Hamlet alone, amoxicillin, and you see here when we combine Hamlet and amoxicillin, something changes. So you see this green part here that is increased. And this green, it's Lactobacillus crispatus, which is used in probiotics already, especially for women, urinary tract infections. And apparently has a probiotic function in the oral cavity as well. So, and we are now going on to investigate why we are seeing this kind of effect with isolated bacteria. So here you have another one that is being done already, microbiome repair. It's done not for antimicrobial resistance, but there are studies showing that fecal transplantation can help in reducing the carriage of resistant bacteria. So there are multiple case reports describing decolonization by this fecal transplantation. And also there are some hospitals that they are creating banks to store fecal samples. So that the day you get sick, they can go back to to fecal samples and maybe use that in the treatment. And apparently it can also have an effect there. So this is a good review on this. So another strategy that is also on phase 2B clinical trial, what they are doing is that if you're using an antibiotic like beta-lactams for a condition that is not in this region, the gut region, that they use this ribaxamase that breaks down the beta-lactam antibiotics so that the antibiotics don't disturb the microbiota where they are not supposed to act. Here on diagnostics, so this was done with preterm infants that have a simple microbiota, and they are able to do to reduce the time for metagenomic sample processing that usually takes days. So they are able to get significant data for the resistome down to 10 minutes. So that could be something that could really help doctors to have a quick diagnostic before or when they are deciding to use the antibiotics. So to conclude, as a summary, for several bacterial pathogens, most antibiotic exposure occurs when they are not the target organism. Antibiotic exposure at any age is associated with increased antibiotic resistance in most studies, but with dramatic changes at early age. Individual variation responses, including, there is an individual variation responses, including which genes are enriched and for how long. And as our understanding of the collateral impact of antibiotic advances, novel strategies or development of current strategies will probably appear to fight antibiotic resistance. So the situation now is that we are really in a race there against antibiotic resistance, and the horse we are driving are antibiotics that are stopping working. So we need to understand antibiotic resistance better, and we need novel strategies. And I would like then to finish by acknowledging this fantastic group at the University of Oslo. Special thanks to a child that is doing the bioinformatics in these studies. The Oslo University, our collaborators at the Oslo University Hospital, the patients that volunteered for this, our collaborators in India on the preterm infant studies, TCS that is represented here today, they will be talking now, and the Lady Hardinger Hospital, and our collaborator in Lund University working with the Hamlet. And super thanks to our RESISPART team. That is a great network behind discussions and ideas for these projects. Thank you.
Thank you very much, Fernanda. I think these kind of studies are really, really important to show the impact of use of antibiotics, not only for infections, but also on the normal flora that we all harbor. So it's so nice to see these documentations and data coming up. I will see if there's anyone in the audience that has a question to Fernanda. Yes, there are two at least. Let me start from the back. Are you ready?
Thank you. Hi, Fernanda. Thank you. Good morning, everyone. I was just interested in the individual diversity in the proportion of resistant organisms between twins. So how did you look at this diversity between children at a young age? Maybe was due to differences in immune systems, immune response or between different sources of microorganisms to the child, to each child. They are from the same family. So looking at how to modulate initial acquisition of resistant organisms, it would be important to look at factors that could influence on this acquisition or not. So
you have a good point, really. There may be several factors. For these patients, we collected just microbial data. And actually, to get data from the human side, it's very difficult. So you need special approvals and everything. And also these are children that are in the hospital, preterm infants. So it's a special group. You cannot just get to get samples from them. It's really tough. My children, they were premature babies, and I remember them making small holes on their feet 3 times a day, just to squeeze whatever blood that they could. And it's really a small amount that can be taken. But there may be factors that are giving the difference that we are seeing that we don't know yet. But what we imagine is that they are getting many of these bacteria in the hospital. The hospital environment is probably a big source.
Sharmila.
Great talk, Fernanda. So your comment on fecal microbiome transplant, you say that's actually people are using it, but they don't check the antibiotic resistance bacteria in the donors. So what are your comments on that? Isn't that they should check that before giving because they will transfer the resistant microorganism to the recipients, right?
Yeah.
So what are your thoughts on that?
Yeah, that is a very important point that has actually been it's been discussed, the risk of acquiring resistance genes from a donor, an external donor. There have been cases in the States where resistance was acquired, so that was a setback to this. But it is possible, so you would need a screen, and that is important. I think in some place they do a screen before, but how thorough it is, I don't know.
Thank you very much, Fernanda, for this speech. So then I'm going to introduce our next speakers, and it's a couple of them. They come from India, which houses 1.4 billion people. That is 700 times more people than you have in Brazil. Can you imagine governing these people, having an overview and controlling what's going on there? There are 2,800 times more people than in Norway, just to put it in perspective. So Sharmila, she is a distinguished chief scientist at the Tata Consultancy Services, which is the second largest market capitalization service in the world. And Anirban, he's the principal scientist at the R&D division of this TSC. And they work with everything from genome informatics, microbiomes, mathematical modeling, algorithm development, and analysis of all omics data, and all this magic to me. So I'm honored to have you here. Please, the floor is yours.
Thank you for the kind introduction. Good morning again everyone. Okay, so the title of our talk is Can Metagenomics Help in Rationalizing Antibiotic Use? You heard a fantastic talk by Fernanda just now. And towards the end, we'll talk about the possibilities ranging from public health policy to clinical decisions. So you all must be aware of the microbiome. This is just a starting slide to show that human body has, equal to the number of cells what we have, or maybe more than that, the microbial cells, and they play very important role in our health and well-being. So if you look into the microbiome in our body, there's a fine balance between the different kind of microbes which are there, and majority of them reside in the gut. So I'll focus mostly on the gut. And there are commensals, there are pathobionts, there are symbionts, and there's a fine balance amongst them, and that's very important for our health and well-being. And what happens in a disease case, that there's an imbalance which happens, pathobionts become more, and then the disease, you see the disease. So there is a correlation which has been seen when there is an imbalance. You just heard about what happens in the antibiotics is given. So when the antibiotics is given, there is some kind of imbalance which happens, and amongst this amongst the microbes which are there. So the important point is that so the metagenomics actually helps us to understand what is there in our microbe, the microbes which are there in our body, in different body parts which are exposed to the external environment, and which can probably also look into the pathogens which are there. Some of the pathogens which cannot be cultured, also you can look into those. And antibiotic resistant genes. So we just talked about what happens when the antibiotics is given to the bacterial community which are there in the body. But what we are talking about, that there are bacterial groups which are there within our microbiome which have the antibiotic resistant genes. So can you identify antibiotic resistant genes? So we can do that through the metagenomics approach. So metagenomic approach can identify the antibiotic resistant genes, the pathogens which are there, and we are talking about not just the individuals. You can do it for the individuals as well as at the population level. So this is the gist of the metagenomics. The way metagenomics can help us in understanding. I'll not go into the risk and assessment, wellness monitoring, prevention stratification. Let's go straight into the antibiotic resistance and the gut microbiome. So we're focusing on the gut microbiome because when we take the antibiotics, they do get into, and the microbiome which are there in the gut, they do get affected. So as we know that the antibiotic resistance has been observed because of the misuse or the overuse of the antibiotics, right? So what happens is that when you have the antibiotic resistant bacteria in the gut, they detrimentally affect the efficacy of the antibiotics. So whether the antibiotics is going to work efficiently or not will depend on the resistance bacteria in the gut. So and when we talk about the resistant genes, it is not necessary that the resistant genes are, the antibiotic resistant genes are present in the pathogens only, but they can be present in the commensals as well. So the commensals can harbor this antibiotic resistance still, and they can transfer this antibiotic resistance to the potential pathogens. And these potential pathogen bacteria can then, once they acquire, they can increase the chances of survival in that particular community. And with the antibiotic pressure. So what we did was, this is an old study which we had done about a decade ago. So we wanted to understand whether there is any geography-specific trend of the antibiotic variations in the resistance profile in the gut. This is the study we decided because we were wondering about whether what happens, the antibiotics are differently used in different geographies. So is there any geography-specific trend? So what we did was, this was published, and what we did was, we actually that time asked these questions. First is, how do we identify antibiotic resistant genes in the gut microbiome, the data which you collect from the different individuals, which bacteria harbor them. Is it the pathogens, is it the commensals, or pathogens and the commensals? How do we characterize overall extent and spread of resistance in individuals between the different diverse groups? You're talking about the abundance and the diversity, right? And is there any geography-specific patterns, what you see of the antibiotic-resistant genes, across these different population, different things, and which genes facilitate these transfer? These are the questions which we asked that time, and what we did was at that time, I'm talking about 10 years ago, that there were only 275 individuals for which the WGS data sets were available. So there were no studies which were done to check the antibiotic resistance, the variations across different geographies. So, so we looked into the abundance of the antibiotic resistant genes and the diversity of the antibiotic resistant genes. So these individuals were from different parts of the world, American, and from the Europe you had Danish, Spanish, French, Italian. There were no data sets which were there from the Norway. And then we had Japanese, Chinese, and we had some which we had done for other Indian children. These were included in that, and the whole idea was to evaluate the global trend of the genes conferring resistance to about 240. So we looked into the 240 antibiotics to which these people, to look into all of these. And the methodology, I'll not go into the details. So from this, what we did was, as I said, that we looked into the abundance of antibiotic resistant genes, which is basically nothing but the total number of antibiotic resistant genes detected in million base pairs of the corresponding metagenome. So that's the abundance. And the diversity is basically number of antibiotics against which the resistance genes were detected per million base pairs in the sequence data. So these are the two things which we looked at that time. And this actually shows the global trend. So we see that out of the 240 antibiotics which we looked at, the resistance for about 53 antibiotics were seen at that time. I'm talking about, again, 10 years ago. The situation will be different now. But what is very clear from here, the bottom ones, what we see, tetracycline, bacitracin, vancomycin, and so on, these resistance to these have been seen in most of the samples. Most of the geographies, we do see that. So, and which is not surprising because these are the widely used antibiotics in all the countries. So this is what we see. So this is something which we saw. Then we wanted to see which are the sources from where these antibiotic resistant genes are coming from. So what we see is that most of them, they are coming from unknown bacteria which have not been cultured. So they belong to different phylum class and the different phylum. For example, the tetracycline, which I said that the antibiotic resistance to tetracycline is highest, what is seen in all of them, they actually primarily originate from bacteroidetes, and some of the genera belonging to bacteroidetes and Prevotella, and the family is Clostridiaceae. These were seen to be the harboring the tetracycline resistant genes. Similarly, for vancomycin and bacitracin, we could see that bacitracin primarily originated from firmicutes. We also saw some which were bacteroidetes and Prevotella, proteobacteria. For us, for the vancomycin, we see the genes are mostly from the firmicutes. So this indicated that different kinds of bacterial groups harbor different antibiotic resistant genes. So having seen that, then we wanted to see the country specific. So if you look into these, on the top one, what I have is the diversity related to this is the diversity, and the lower one is the abundance. And what you clearly see here, that in the southern Europeans, the Spanish, French, and Italian, which is shown here, and the resistances, they have the resistance to wider array of antibiotics compared to the American and the Danish here, right? And whereas one striking thing which you will see between these abundance and the diversity, look at the Chinese one. Fernanda was talking about Chinese one, that the abundance is high in the Chinese, but if you see the diversity, it's low. That's the lowest compared to all other. So that was surprising because we thought that if the abundance is high, the diversity also is likely to be high, but that's not so. So which means that the Chinese have higher number of genes conferring resistance to the same antibiotics. So there are higher number of genes conferring resistance to the same antibiotics, and this is something which and one interesting thing which we found for the Chinese is that 34 antibiotic resistance genes were found only in the Chinese gut microbiome, which were not there in any other samples. So then we looked into the country-specific antibiotic resistant patterns. And if you look into this, if you see that on the right, we have this heat map. We see that antibiotic are arranged on this y-axis. And if you see the American, for example, you see that cephalosporin and phosmidamycin, these two are highest, which we see from, if you compare with respect to all other geographies, these are higher in Americans. Whereas in case of the Spanish, you see that chloramphenicol, which is higher in the Spanish ones. And the Chinese, which I mentioned about in the previous one, that which had very different diversity and abundance compared to the other countries. And you see that these antibiotics resistance were seen in the Chinese. And there's one which is this particular gene, which actually has resistance to 3 of the antibiotics, which is seen very high in the Chinese population. So, so what we did was, we had all these individuals which are antibiotic resistance profiles. So individual 1 is, resistant to which antibiotics, you have that, the individual 2 and so on. So for all the individuals, we had a profile of the pattern of the antibiotic resistance. And if we cluster those, and we found that we could group those individuals based on the antibiotic resistance profile into 2 groups, cluster very clearly 2 groups, and we call them as the resistotype, meaning that this one particular cluster, for example this cluster have the similar antibiotic resistances profiles, okay? And these ones had few Chinese and rest of the world, whereas this particular cluster, which we call as the resistotype 2, had all Chinese population. There were no other population which were there in this, in the resistotype 2. So if we try to group these resistotype 1 into finer groups, then we see that we get 3 groups. And one is mostly 60% of the US people, and the second one is which is a mix of the European and the Japanese population. So these are basically showing which group resistotype has how many kind of the individuals from the different geographies. So so basically from this, what came out that the individuals could be grouped into clusters based on the resistance of the gut microbiome. Now, which are if you look into the resistotypes, which are the abundances of the antibiotic resistant profile, what are the antibiotics which are resistant to? This actually shows which are the ones, just to show that the resistotype 2, which is the Chinese one, has, you can see that this is the one which I was talking about, which is resistant to 3 antibiotics, which is very high in this. And also the tetracycline is highest in the Chinese one. Now this was the work which we had done about 10 years ago, but then nobody had done any other, we haven't seen any work which had compared the other, again the geography wise. But after that we moved into so many other projects, so we really didn't look into that. But this is a study which came out last month, which is what they have done is they have taken the 214,000 metagenomic samples from different environments. It's not just the human body, but also in the soil, different environments, and so on. And what they have done is they looked into the antibiotic resistances in these. So if you can see that for the gut microbiome is just a small proportion of that. I mean, of course, it's large enough, but the gut microbiome is somewhere here, which is here. So this is the one which is, but all other organisms. They also see that some of the findings what we had, like for example, the highest number of the antibiotics resistance is seen in the gut microbiome. But their focus is more on looking into antibiotic resistance in different, whether it's animals or the poultry or soil and water and so on, apart from the humans. So what did we gain from this knowledge? So we saw that the country-specific pattern of antibiotic resistance probably exists either due to the specific overdose of the certain antibiotics in that particular geography or country, or due to the presence of organisms harboring resistance against these specific antibiotics in respective countries. And what we found that the observed increase in the antibiotic resistance in the southern Europeans, which I had highlighted there, it actually correlates with the earlier report. So we looked into and found that some report had mentioned higher level of self-medication or outpatient antibiotic usage in those southern European countries in those. So which actually indicated why that antibiotic resistance was high, the diversity was high in those. What we feel that the insights what we have got from this study will be useful in implementing better antibiotic treatment regimens in different geographies. It should be geography specific. Now how this knowledge can help? The metagenomics derived knowledge of the resistant genes in the individual can complement antibiotic sensitive tests while making the prescription. The doctor should be able to look into these while making the prescription. And the geography specific trained to antibiotic resistant gene prevalence combined with the local antibiogram derived insight will equip public health administration to issue the right guidelines for the local context. So can we do something to reduce the unnecessary prescription is the question which we asked. And the next part what Anirban is going to present is our recent work, which is still not published. We have filed the patent, but that's the recent work towards answering this particular question. So Anirban is going to cover that particular one. So I'll give it to Anirban.
Thank you. So thank you, Dr. Sharmila, and also thank you, Dr. Ulf, for the kind introduction. Okay, so means at the beginning of our talk, Dr. Sharmila mentioned the two possibilities how metagenomics can help in rationalizing antibiotic use. One being, so she spoke about the way, means it can help us frame public health policies, and the another possibility was clinical decision support. So I will focus on this aspect. First, let us recapitulate what does metagenomics allow. So this new technique, this emerging technique, so that it helps us to understand what microbes are present in a sample, right? So that's the primary thing. And now we are also using the same for understanding the repertoire of antibiotic resistance genes that can be present in that sample. Now, if we think carefully, it can also be used as a potential diagnostic tool, right? So it is helping us getting to learn means what microbes are present in there, which can include the pathogens. So we can use metagenomics to understand infections, and given the lowering costs of the DNA sequencing technologies and the quick turnaround time, slowly the technologies are evolving every day. So this actually can be there can be a big scope of using metagenomics in using it as a diagnostic tool to confirm infection. And actually the world is moving in this direction. There are many recent publications indicating that. I have picked a very recent one. I've picked a very recent one. It was published just 2 months back. It's from a group from the Hong Kong University, and they have shown that using a metagenomic technique, they have been used to confirm sepsis. They have successfully confirmed sepsis, and they have predicted mortality as soon as the first day of infection, first day of ICU admission. From a different part of the world, this Carriers, this company, it's a California-based company, they actually have marketed a microbial cell-free DNA-based. It's also a metagenomics technique. So they are allowing to detect over 1,000 different types of infection-causing pathogens. So they are using, it's already a marketed technique. You can use it to detect, tells us what we probably can do using metagenomics. But I will just take a pause and focus on some things that we cannot do yet using metagenomics. So let us assume we are using such a rapid diagnostic test, which is metagenomics based, and we are evaluating a sample. And so what we can do, we can confirm the presence of the pathogen from this single sample. We can also measure the abundance of the pathogen from this sample, probably compare it against a certain severity threshold, and based on that we can take a decision on prescribing an antibiotic, right? Now, what we cannot know is which way the infection is progressing, right? We have taken a single snapshot, we have taken a single sample. Now, it can so happen that the infection will die down on its own. It will recede on its own, and the prescription of antibiotic may not be necessary at all. Okay. On the other hand, it can also go towards the peak. It can become more severe. That's also a possibility. So now, the US CDC, it says that in United States alone, over 30% of antibiotics, they are unnecessarily prescribed. Now just imagine, means if we could make out at the beginning that which of the infections would recede on its own and may not need antibiotics at all, that would be wonderful, right? But unfortunately, okay, some interruption. But unfortunately, we cannot know that. Means, so we have taken a taken a single time point, a sample from a single time point. We don't know whether it belongs to this green dotted line, where it has already passed the peak of infection, or it belongs to this red dotted line, where it is yet to peak. So we get to know about the abundance of the pathogen, but metagenomics cannot tell us about the viability of the cells, the vigor of the cells, how quickly it is growing and replicating. So longitudinal sampling can solve this problem. I can take samples at time point A and time point B, take the delta TB minus TA, T2 minus T1, and get the answer. But we are all talking about rapid testing. We cannot wait for another day to take the next sample, right? So this does not help. Time is precious. So now let us try to come to a solution. So in our group, we viewed this solution initially as a metagenomic problem. And we asked the question that when we are doing metagenomic studies, are we also measuring dead bacteria? So you know, right, when we are doing a metagenomic study, we take all the DNA present in a sample and go for DNA sequencing, right? So those DNA that can come from a live bacterial cell, it can also come from a dead bacterial cell. After we do the sequencing, there is no way of distinguishing between them. And that can create a lot of problems. Means when you are actually counting, we are making taxonomic profiles, abundance tables, this thing can create problems. So can we have a single sampling based metagenomic protocol which helps us with this? Definitely with longitudinal sampling, we could make out about the cell viability, but can we do this with a single sampling experiment? So let us go back to our microbiology classes. We got inspired by the bacterial replication process. Okay, so if you remember, it's a circular chromosome. The replication starts at some point called the origin of replication. The bidirectional replication fork forms. It proceeds in two different directions. And slowly the new strands, they keep on getting synthesized, and the forks finally collide at a place called the terminus of replication, and we have 2 new chromosomes, right? Now, if we think carefully, at any particular time point when this replication process is happening, if we take a portion of the chromosome which is closer to the origin of replication, so it has already replicated, the replication fork has already gone past that area. So it exists in duplicate, right? It's already duplicated. There are 2 copies of that portion. Whereas if you take something which is closer to the terminus of replication here, so that has not yet duplicated, right? The replication has not happened there yet. So it is still present in a single copy. So now if I take a bacterial colony, so it's no longer a single cell. It's a consortium of many bacterial cells. And I am doing a shotgun genome sequencing. I am breaking up all these chromosomes into small, small pieces, and I am doing a DNA sequencing, and I am mapping back those reads to the genome. So what will happen here, I will find a larger number of fragments that correspond to chromosomal regions which is closer to the origin, and a lesser number of fragments which correspond to regions which is closer to the terminus. So, and it can be fitted with this kind of a straight line. Some bacteria which is growing very fast, this slope will be very steep. For some bacteria which is growing very slow, the slope will be almost parallel to the x-axis. So this slope can tell us about the growth rate of the bacteria. So this kind of a concept has already been exploited by another group. So this was a paper from the Weizmann Institute of Science, Israel, and they use this in a metagenomic scenario using deep WGS sequencing. So essentially they use this read coverage and which has an inverse relationship with the distance from the origin of replication, and calculated both the abundance of bacteria as well as their growth rates using very deep WGS sequencing. But that is a problem. If we need deep WGS, it's a very costly affair, and we cannot go to the clinic. So it will be cost prohibitive to take this kind of a technology to the clinic. So we again ask the question, can we exploit this using a low-cost amplicon sequencing based method? So amplicon sequencing, I think all of you would be familiar, means the way we do 16S rRNA based metagenomics. So that is amplicon sequencing based method, wherein we target one particular gene or one particular genomic loci, amplify it, and then go for a sequencing experiment. So here, if we think carefully, if we can identify 2 genomic loci, say gene A and gene B. So again, a small maths lesson. So how many points do I need to join a straight line to get a unique straight line? Only 2 points, right? So in the shotgun sequencing, we were actually profiling all the genomic loci for all the bacteria. But we don't need that to draw this straight line, this slope. I only need 2 points along the genome. So if I can identify 2 genes, gene A and gene B, which are separated, and we can get their read abundance, we can as well draw this straight line, and we can make out how fast that particular bacteria is growing, right? This is clear. Okay. But if we come to a metagenomic scenario, there is one more challenge. So each of that gene A and gene B that I identify, I need to be able to map it back to the origin, the organism of origin, right? Because there are thousands of bacteria, all of them will have this gene A and gene B. So after I have sequenced them, I need to know that this gene A belongs to this bacteria. So gene A, all orthologs of gene A, they will map back to different source organisms. Similarly, all orthologs of gene B will map back to different source organisms. And all these bacteria, they will have their different growth rates. So for each group of bacteria, for each species of bacteria, or for say each strain of bacteria, I will need to draw that kind of a graph for each of them, right? So for that, we need this gene A and gene B to be phylogenetic markers, which has enough information in them that will allow me to map them back to their source origin. So one choice is obvious, 16S rRNA, we have been using that. The other choice that we chose, that is CPN60, another heat shock protein, which is also quite widely present in almost all the bacteria. And that is also a very nice phylogenetic marker that has much very rich phylogenetic information, which allows it to be mapped back to the source organism. So how does the workflow look? So it involves a one-time creation of a database, because I just said that there's a gene A and gene B, one located closer to the origin, one located closer to the terminus, but it's not like that. The position of these genes in different bacteria will vary. So first we need to create a map of where these genes are located in each of the bacteria that we are going to learn about. So we create a database of the location of these two genes, CPN60 and 16S, across all bacteria. We take care how many copy numbers are there. Based on that, certain normalizations will need to be made. And once that database is created, we need to do a duplex PCR amplification followed by sequencing. So the only thing that we will need in addition to the current 16S protocol is an additional pair of primers. Earlier we were only amplifying a certain region of the 16S gene. Now we will need to amplify the CPN60 gene also in addition. And once we have the amplified product, we go for DNA sequencing. And the read abundance that we get from these two genes, we can plot it in that nice graph for each of the bacterial species, and we can know about their taxonomic abundance as well as their growth rate at that instant. So we call this SITAR, Simultaneous Investigation of Taxonomic Abundance and Replication. It's a musical instrument, Indian musical instrument. We thought this would be a nice name. So right now we are optimizing this duplex amplification and sequencing in our lab. We also did some simulated experiments with some deep WGS data. The results are very promising. I will not go into this today. But finally, means when this kind of a technology comes to the clinic, what will it allow? So it will help in rationalizing antibiotic usage based on, means we will learn about not only the infection type. We are getting to know about the pathogen. We are also getting to know about the stage of the infection, whether the pathogen has already lost its viability. So that will actually help the doctors to prescribe the right kind of treatment at the right time. So we hope it makes a way to the clinic soon. So thank you, thank you the organizers for giving us this platform to share our thoughts. This is the place where we work, me, Dr. Sharmila and our team, we work. It's called TRDDC, Tata Research Development and Design Center. So the next time any of you are visiting India, we would expect that you visit here. We will be eagerly waiting for you. Thank you.
Thank you both. Sharmila, if you would come back up here. Yes, and we have some questions already. We will start with, yeah, would you give it to Babaton first, please? To Babaton. Oh. Yes.
Thank you, Dr. Sharmila and Dr. Dutta, for the wonderful presentation. My first question goes to Dr. Sharmila. I was trying to look at, I know the two options are probably not good, but I was wondering whether there is a lesser of the two evils between trying to optimize for high abundance and low
diversity.
Low diversity. And would there be any specific situation where you might be like, oh yeah, maybe if we have this might be better overall for the population, and if you have the other, this is worse for the overall population. And did TCS had any of those considerations?
See, ideally, we would like a lower diversity of the antibiotic resistant genes and the lower abundances. and what I was showing that, this is not the so. In both, the different geographies, what you see. But you are saying that the optimum, this thing, you can't say what should be the optimum, the diversity value or the, we would like as low as possible, the diversity as well as the abundances. Did that answer your question? Yeah, thank you.
Yeah, thank you, Dr. Sharmila and Dr. Anirban. So I have a one question to both of you. So first, Dr. Sharmila, you showed like you can able to distinguish these geographical location into resistor types.
Yes.
Would you have also got the anterior types, and have you checked whether anterior type shapes the resistor types?
Yeah, we haven't checked that whether the resistor, the anterior types will, but my guess is it may not, because the anterior types, you really see that there is an overall the microbial, the microbiome in the geography, but the resistance, the resistor type will come onto the usage of the the bacterial, the antibiotics, right? So I don't think I would expect, a correlation between the resistor type and the anterior type. But we haven't looked into that. That my guess is that no, we can't.
I see. Because there's a is what? Oh yeah, I'm sorry. Because these days there is a lot of studies which show it's actually the bacterial composition that shapes the resistome in this microbial community. So they find a good association between them. That's what I was wondering. But yeah, there are studies which show.
But it will be interesting to check that out.
Yeah, awesome. And can I ask just a question to Dr. Anir? Amazing research that you are doing. But I just got confused at the end because you are anyways using sequencing. So how does it helps in a diagnostic tools to get the decision, like rapidly decision? I got a bit confused at the end, like.
No.
So you're not doing the WGS, right?
Okay.
You're doing just the 16S. Apart from the 16S, you are going to do the CPN60. So it's in the diagnostic setup.
Yeah.
You don't want to go with because you do want it to be affordable. Yeah. So you're going to do the 2 genes instead of the entire whole metagenome, right?
So the primary thing is to not only look at the presence of the pathogen, also its viability. So that's the whole new thing. Okay, and more so as Dr. Sharmila said, and we should be able to do it at a low cost. Means WGS already allowed it. So in Corem and co-workers, they showed it in 2016 that using a very deep WGS, means they were looking at some 60-70 million reads at least per sample to be able to capture the growth rates. But to go to that depth, the kind of sequencing power you would need and the cost that you would need, that would be huge. Means it would be cost prohibitive at the clinic. So we wanted to check if we can do it with amplicon sequencing. So in this case, the cost is almost equivalent to 16S sequencing. You just need another set of primer during the amplification, right? So that way it is cost effective, and definitely the time has not come that still the turnaround time for 16S also means it's around 2 to 3 days, but it's going to decrease, right? Dr. Fernanda showed that 10 hours turnaround time with that nanopore sequencer, right? Oxford MinION sequencer. So if we use those kind of technologies, then this becomes possible.
Yeah, thank you for Dr. Dutta. I thought it was wonderful strategy, this gene A and gene B from chromosomal replication. But I was just thinking if it wouldn't be also easier to look at the transcription of housekeeping genes instead of just sequencing different regions of the chromosome of different organisms are done.
Yes, ideally you could look at transcription, but definitely as we know, RNA is more unstable, and going for RNA sequencing is a bit difficult than DNA sequencing.
Yeah, and so the costs would be
and
high.
also we would also we need to know both, right? Both the abundance and the viability. So if you only go for RNA sake, probably in some cases we will miss the abundance part, unless we can count the actual number of chromosomes or fragments coming from the actual number of chromosomes of the cells.
Okay.
So that's also a possibility as you suggested, but in my opinion, probably going for the chromosome, the DNA would be the better option.
Okay, thank you.
Good. Sharmila and Anirban, thank you so much. You're going to get a little different gift from the rest of us, simply because this is easier to take back to India than the other alternative. So thank you so much. Should we have the photographer up here? Obrigada. And should we do it all three at once?
Yes.
So, and one for you, Anirban. Thank you so much. Thanks. And then we leave the speaker and the phone to Nancy, that is going to host us through the next session. You can be up there or down here, as you please.
Hello, everyone. It's my pleasure to introduce our next speaker. That's Dr. Chen, and we call him George as well. So George is the director of Bioinformatics Core at the Forsyth Institute in USA, and he has extended experience in oral microbial bioinformatics. And he has been developing bioinformatics analytical tool for the next generation sequencing. And he has also developed several oral microbiome databases and has authored more than 80 peer-reviewed journals. And they have over 4,000 citations. And it's our pleasure to have you here today, George, and the floor is yours. Thank you.
Thank you, Nancy. Okay. So should I get to my slide, please? Hi, everybody. My name is George, and it's really good to be back here to see many friends' faces in person. And I know that both John, our next speaker, and I are sitting between our lunch and our hungry stomach. I'm hungry myself, so I'll try to speed it up. But hopefully, at the end of my talk, I'll give you some take-home message that will be inspiring to you, just as it did to me. So my topic today is, since the previous speaker or this whole meeting theme is to combat the antimicrobial resistance. And so this is just the thing that I can think of, that bioinformatic tools can help us to combat the AMR, like can assist us with diagnosis, with prescription treatment. I think you can read this faster than I can read it. So I'm just going to give you a couple of seconds, and I'll face forward. And so what is resistome? Vanilla just mentioned that it's the landscape of antimicrobial resistant genes. So you can think of it, a collection of these genes, and the source can be from different environment, human, or you can look at it as or maybe the whole global resistome. But what I'm interested in as a bioinformatics is really doing the data analysis for these data type. It's DNA sequences, and I'm going to give you some overview of what's the tool available for doing the data analysis for these type of sequences. And so this is just a paper published in 2007. They emphasize that, resistome is a collection of the antibiotic resistant gene, but he also points out that there are many intrinsic, let's see if I can do the pointer, intrinsic and silent cryptic or even portal resistant gene occur in the reservoir of these, the Earth. I think the point is that we need to know that bacteria has been on Earth, since 3.4 billion years ago. And compared to us human, which is a sort of a short blink of a couple minutes in terms of the Earth's history. If you think of it as a 24-hour clock, we only appear in the last 2 minutes, right? And so bacteria has been on Earth encountering all kinds of compound and challenges. And so they have a lot of available tools to combat whatever the environment throwing at them, including the antibiotics we give them. So this is just a very difficult battle to be against them. So how can bioinformatics help to combat AMR? Basically, these are the points there. These are the category of application that the bioinformatics can help. But basically, we just are getting a lot of data, including clinical genomic sequences data, and most of them now you can get it from the cloud. And this is just imagine that all these data you have to go through this sort of a bioinformatics black box, and then it will give you a result that will be useful in all these areas. And so I did a little survey for a lot of these data bioinformatics tools. You need databases to make sense of it. And so there are a lot of databases around. And I look at the AMR database platform. There are 36 different types of databases around. Some of them are sequences, some of them are clinical or administration data. And so these are the 6 categories of the database that are from the previous list. And there are like chemical library, antibiotic discovery and development, approach or stewardship, and these elimination clinical data. But what I'm interested in most, because I'm a microbiologist, so I'm most interested in organism sequence databases. And so this is actually a review paper just published this year. They listed 13 of most commonly used database for antibiotic resistant genes, actually specifically. And so this paper also evaluated which one is the best. And so far, the CAR, the Comprehensive Antibiotic Resistance Database, is the most often used one and the more comprehensive because it has the more genes. But lately, there's a new database called NDARO. A slightly higher number of antibiotic resistant genes and overall sequences. And so these are the databases. Let me see if I can go back. Sorry, moving too fast. So those are the databases the tool can search on, based on, and these are the tools that's been reviewed for that has been used for antimicrobial resistance research. And there are altogether 47 of them that I can count from the paper. But the basic idea is that when you have an analysis pipeline or tool, you got the input data, mostly when I'm interested in DNA or protein sequences. And there are a lot of these basic dissection tools you can do. Most of these are sequence alignment based. You have these are non-sequence, and you search against a database of reference sequence that's non-antibiotic resistant gene. And from here, you can detect the different types of antibiotics or determinant or mutations. And so I just point out that all these the base method, they are all alignment based. But most recently, I came across with this idea that, hey, I mean, is there some other way that's other than sequence alignment based, and it's called artificial intelligence. There are more and more tools using the artificial intelligence to help with the bioinformatic analysis of these DNA sequences. And so why AI? Why don't we like the alignment base? I mean, it's still a gold standard for if you want to identify a known sequence that it's gene A or gene B. Alignment is still the gold standard. But there are some drawbacks. For example, when alignment, you need to choose a cutoff. If there's 100% identical, no problem. But what about 60% identical to the reference or 50, 30. Where do you cut off to choose, hey, this is gene A or gene B? Also, that percentage identity is based on alignment length. So if it hits 100% to a very small region, and then the gene is much longer. So do you think that this is the same gene? So there are these cutoff that if you choose cutoff too high, you will lose something. If you choose cutoff too low, you will have a lot more false positive. And so the AI analysis they are not relying on a sequence alignment. So in my opinion, it can be a good supplemental alternative method to the traditional alignment-based analysis. So I'll give you some quick introduction of what is artificial intelligence. This, the first artificial intelligence was, the first idea was from Alan Turing, and he is considered the father of the AI. And there's a motion picture movie for his life, and it's very good. You're welcome to, you should be watching it, very interesting AI. And so the scope of artificial intelligence can be in these three different scopes. Any program or computer program that with the ability to learn and reason like human, we can call it artificial intelligence. And it doesn't even have to be DNA or all kinds of data. And then the more general one is that we given some basic algorithm, and then the machine or computer can decide themselves and give us the best answer. And this is called machine learning. And lately, in the past 2 decades, there is a booming renewed interest about the deep learning. It's a subset of machine learning of these that utilized the artificial neural network. And so this is to teach the computer how to think. We don't give it any rules. Or there are still basic algorithms, but computer will have to come up with their own rules. And that's why it's the most advanced form of the artificial intelligence. So this is a reiteration of their differences. The traditional machine learning, human gives some rules and computer would decide the answer for us. And the machine deep learning is that we give it a very generic rules, but for any given data, we have any given question. The computer has to figure out their own rules. A lot of time that those rules, we don't even understand it, but the computer can use those complicated rules to make a decision for us. And so these are the typical machine learning, not the deep learning. And we have been using it a lot in like linear regression, logistic regression, and I also have a publication in the random forest and develop an online tool. But this is so-called only machine learning, not a deep learning. And also, this afternoon, Archer is going to present his online tool, his excellent tool, include a lot of analysis function and also include some machine learning tool that you can use. And you can hear more about it this afternoon. So what is artificial neural network? It's inspired from the biological neural network. These are the neurons. And the way our neuron network works, that we have a signal, incoming signal, and then it was transmitted to different nodes, and different nodes would do something different and transfer to the next one. And sometimes they can feedback to the previous node, and it would determine how the action is going to take. And so the artificial neural network is similar to this, but not exactly working the same because we still don't really know how human brain works. And so there are different layers of these nodes, and each layer is sort of a computational, mathematical computational results. And think of these arrows, they're just one equation. And then from the input layer, you give you a lot of calculation and give some result. And based on this result, you can have multiple layers of these calculations, and hopefully it can come to a conclusion and answer the question. And these multiple layers of the repeated calculation is the deep part of the deep learning. And so I always am fascinating how human brain works. I always give this picture, and this is also a practice question for people who are interested in AI, and see if computer can even approach to the level of human brain. So I'm sure that everyone here, if you look at the picture here, it will be pretty easy for you to tell that, hey, this is a cat, this is a dog, and regardless of their color, their size, their age, and these doesn't even have sound or motion. We can only rely on picture, just instantly recognize that it's a cat, it's a dog, based on our previous trained knowledge, right? And when we recognize it, we're not even thinking that, hey, based on, we're not going through any rules. There's no rules. Our brain instantly make a decision for us. And this is the amazing part. And more amazing that if you look at this picture, sorry, this is important, I need to go back. So if you look at this picture here, there is a dog behind the cage, right? And our human brain can steer, I bet all you can see, there's a dog behind the bars. And I believe that of this picture, these will be the most challenging that computer AI can differentiate it or say that it's a dog or cat, because it's just a complicated image. But our human brain can do it easily without even thinking much. And so we try to simulate how our brain works. And these are the artificial network. We just give it basically the artificial network. You can think of it as layer by layers of complicated mathematical calculation. And whatever different, you can give it a different type of data, image, metagenomic sequence data, clinical data. You give it to these layers, artificial neural network, they will perform tens of thousands of calculations. And they will just come to their own conclusion until they have a list of rules, and they can correctly predict the result. Of course, this is a training process. We have the answer already, and then we train the machine to think, to make their own rule to help us to get the right question. And if they have the rule set up, we can then use these learned rules and apply in the real life problem or questions. And so the more important thing is that no matter what type of data I give it in, there's a numeric transformation, because these are mathematical calculations. And so no matter what type of data, you need to somehow transform it to numbers. Otherwise, computer cannot. I mean, every computer works based on number or binary data, 0 or 1. And so you have to, first step is to transform it to numeric data. And so before I go into the more data transformation, the AI has been used quite widely in many research, including the cancer research, microbiome research, clinical dentistry, and also the antimicrobial resistant metagenomic research. There are many methods proposed already. So the first type of data transformation, we are working on it, and we have preliminary result. I call it nucleotide frequency, because if you get those metagenomic sequences, there are different samples, different number of sequences. And you be even assign it to different species or different genes, the antimicrobial resistant gene. Different sample will have different numbers of genes. And so we use this to train the AI. They would not only learn from these numbers of genes in the training set, but if you give it a real-life sample that has other species or other genes, then the machine probably won't give you a perfect answer, right? And so my idea is that if we transform all these sequences to chemonucleotide frequencies, and for example, if this is a random sequence, we can say that the mononucleotide frequency, there are 4 G in this sequence, 2 A in here, 1 T, oh, actually 2, sorry. Oh, wow. T and C should be switched. Sorry, I probably messed up this number. Anyway, you get the idea. This is the number of mononucleotide. And you look at the dinucleotide, how many G? There are 2 GG and 2 GA, or 1 GA and 1 GT, and there are no GC in this example sequence. And this type of numeric transformation, as long as we pick a chemo size, if it's a monomer, it only have 4 different possibility. If they had 2 letters, 4 times 4, 16 possible dinucleotide words, right? And so you can go all the way up. Depends on, you can choose 1 mer to 9 mers. 9 mer has 262,000 different 9-letter words, ATGC, something like that. So it makes that the data dimension fixed, as long as you pick a k-mer size. And it will be easy to take advantage of every sequence in the DNA sequence, whether it's metagenomic, section S, doesn't matter what type of DNA sequence, as long as it's DNA sequence. And there will be no loss of information there. And so this is a typical tetranucleotide frequency. You can see that maybe sample 1, and if it's tetranucleotide, there are 256 different 4-letter words. And so this is just sort of every sample has 256 values, and there are different samples. And then all of a sudden, you can send this data to the machine training. And then this is our preliminary result that the best we can get is right now achieve 88% of accuracy from the small data set we are doing. We use a data set that has 248 samples of roughly equal health and disease samples. And so the blue curve is the accuracy. We can train it multiple times, and then we started from 4 mer to 9 mer, and then the accuracy sort of increased. If you have more words, that means more unique sequences in there and higher resolution to differentiate different types of samples. I mean, imagine if it's only monomer, only 4-letter word, only G or A or T or C, you essentially only have the GC information, right? And you probably won't be able to differentiate what is the disease, what is a health type, or any other clinical condition of the samples there. And so the red curve is the loss, and this is a different function to monitor the performance. And then we found that at 7 mer, we have reached the highest prediction accuracy, about 88%, and lowest are lost. This is my reminder that I need to wrap up. So that is the nucleotide frequency is one way of data transformation. Remember earlier, if you want to ask computer to learn something, the data you are giving them has to be numeric, right? And so the k-mer nucleotide frequency is a good start. But right now, I'm having an even better idea. This term, probably new to most of you, but it's actually a very old concept. It's called CGR, KR, scan representation. So this is yet another creative way of data transformation. I'll explain it more later. And it's very fun, and it can transform the data and transform it to even become an image. So you can say that, hey, it's one way to visualize DNA sequences. And this is actually based on the KR theory. And the idea is that you give them random, well, not random, DNA sequence is not really random. You give a DNA sequence, and it can give you more order pattern of whatever data you can give it. And in this case, it would actually generate a type of image called fractal images. And this was first applied to DNA sequence by Jeffrey in 1990. So it's actually not a new concept, but the new part is that I'm trying to combine this DNA data representation with the AI. This has not been done before. And this is, again, alignment-free comparison of DNA sequence. And so we use the nucleotide frequency. You can pick maybe 7 or 8 and build this type of chaos images, which I will show you. And how do you build it? Again, we have a test sequence, all right? So now this is the same as the one before, but when you get to the dinucleotide, you can do it this way, but what if you have you want to study trinucleotide? You cannot do it this way, but there's another way is that, imagine this is the test sequence, all right? This is one monomer. There are 9G, 6A, 5T, I call it, so 3C. But then we ask the question, of these 9G, how many of these are followed with G? How many of these are followed with A? or T or C. So of these 9 G, 3 of them follow with G, 3 follow with A, and 1 follow with T, and 2 follow with C. And you can ask the same question. Of these 6A, how many of them follow with G or A or T or C, and fill the number in here. And do the same with all this. And all of a sudden, you have a dinucleotide frequency matrix. And then we can convert based on the number of these to sort of an image. And it will be very fun. And again, of these 3, if you want to study trinucleotide, you can ask how many of these GG follow with GGG with a G, how many of these follow with A, T, C. And you can do this, and then the number of the 3-letter words will increase, and we'll put in here. And this is the outcome. So 1-letter word only have 4 squares. We do it by, this is probably a genomic sequence. I forgot which genome it is. And you just keep doing this, and then the resolution of the represented image is becoming more higher resolution if you increase the camera size. All right? And are we seeing any pattern here? I think so. If you look at this square here, it's sort of identical to the small square here. And actually, any of these is similar to the bigger square here. And this type of image is called fractal image. It's any smaller part is equivalent to the bigger part of the same image. And this is a paper from last year. They used this technique to study mitochondrial sequences of human, Iceman, Neanderthals, or chimpanzees. And you can get these are fractal image patterns. But I mean, these are close species. They also sort of compare pixel by pixel, I mean frequency by frequency, or percent frequency. And you compare these two, they can plot out the differences of each of the nucleotide or pixels there. And then all of a sudden you can say, hey, human and chimpanzee, there are so much difference than human and Iceman. I look at that Iceman appear only 4,000 years ago, so it's the closest to human. And I can do this with bacteria genomes as well. These are 4 very different species of the genomic sequences. And we can also already tell that, hey, these all have different of these fractal patterns, right, represented by the KR scan representation. And so from here, the idea is that, well, now we come to the limit of human brain, okay? If you look at this, yeah, you can see the difference. But I mean, if I ask you, hey, which genome, which species is this? I think if I give you 100 or 1,000 of this image, this is not the image that our human brain are accustomed to. And so the idea is that, and this is the hypothesis, we give AI the fractal image generally from any sequence, and AI can be trained to recognize DNA fractal image to differentiate species, clinical samples, or even metabolic functions. If you're only talking about fragments of DNA or something, they only have a couple genes there. And so the application, this is just we're beginning to study this, but I can think of these. First of all, it's, again, alignment-free comparison, and this can be alternative to phylogeny, and it can also do functional prediction, or in a clinical case, it will be once the AI is trained, if they get a sample sequence from a clinic, it can quickly give you, in a couple seconds, give you a prediction whether this disease or health or any other condition. As long as you have that condition in the trained data set, it can give you the quick answer. And so the take-home message for my talk today is that AI is cool. I like it. That's why I'm interested in recent years. And deep learning is deep. If you tell a computer to learn 100 times, they may become as wise as human. Chaos game representation is fun. Fractal images are mesmerizing. And AI plus CGI can have a great potential, and it's a phenomenon. And this is fractal images everywhere. Of course, you can generate by computer algorithm, and you can find this fractal image in nature as well. So, Another goes to RESISPART. Thank you for inviting me here. And RESISPART Explorer, Archer will talk about it this afternoon. And then some of this project was supported by a high school internship at Forsyth, and the SMDI is collaborating with Temple University, and thanks to Forsyth for very core support. That's it.
Thank you, George, for the excellent presentation.
Thank you.
Yeah. So do we have any questions from the audience? Have it. I know you must be hungry, but any questions if you have?
Or you can
any
just ask me during the lunch. All right? Let's do that.
Oh, okay. After the lunch?
Yeah, well, during the lunch. If you have any questions.
During the lunch, okay, yeah. No questions? Okay, so thank you once again. And this video.
Oh, yeah.
So our next speaker is Dr. Jonathan Baker, and he's a staff scientist at the JCVI at the Department of Genomic Medicine. And okay, so wait, I was not prepared for it. And his aim is to discover the effect of oral microbiome on the human health and disease based on molecular microbiology and bioinformatics. And yeah, so he'll be going to talk about the bioinformatics and its application in oral microbiome. So yeah, John, the stage is yours. Thank you.
Thank you, Nancy. Great. Well, it's great to be back here in Brazil. And today we've heard a lot of really good talks talking about how different scientific techniques and technologies can help us understand antimicrobial resistance and find a good way forward for new strategies to combat this problem. And one of the things that I'm going to sort of highlight today is some of the limitations that remain not only with the tools and the technology and the databases, but also what we even know about the microbiome itself, which of course is also very important because most of the tools, as we see, right, rely on databases and sequences, but there's still a lot of unknown bacteria and genomes out there. I'll just try and use the... So start with a little bit of background about the oral microbiota, because as I just mentioned, right, I'm going to highlight some of these limitations and some of the knowledge gaps that exist. And I'm going to do that using sort of a case study of a metagenomic study that we did on the oral microbiome in the context of dental caries, which I think is something that should be familiar to this audience. So just to briefly highlight, the oral microbiota starts out when you're born. It comes from the mother. There's maternal transmission, and at that point, it's pretty non-diverse, right? And then as teeth erupt, that opens up new ecological niches for new bacteria to start growing and adding to the community. And then throughout adolescence, right, we encounter new microbes, and some of those get established. So the microbiome in the mouth gets more diverse. And throughout our lives, then it's consistently impacted by our environment as well as our genetics, but also things like oral hygiene, dietary habits, stress, smoking, and importantly, medications such as antibiotics. And then the microbiome actually starts to get a little bit diverse, typically as we age, as we get into our older years. And of course, the oral microbiome is well known to be the causative agent, or there's a dysbiosis in the oral microbiome as the cause of both dental caries and periodontal disease, which of course are very, very prevalent global issues. But in addition to these, the oral microbiome is increasingly associated in the bidirectional relationships with a number of systemic diseases. And so it's a rather long list. So just to name a few, it's Alzheimer's disease, diabetes, cardiovascular disease, colorectal cancer, inflammatory bowel disease, rheumatoid arthritis, non-alcoholic fatty liver disease, and obesity. And so just within the last probably 10 years, we've started to identify correlations between the oral microbiome and these diseases. So of course, if we mess up the oral microbiome with antibiotics, that can impact these systemic diseases as well, in addition to things that we normally think about like caries and periodontal disease. So the study I'm going to highlight today it talks about dental caries versus health. And so, of course, in dental caries, you have this dysbiotic dental plaque microbiome that creates an acidic microenvironment adjacent to the tooth surface that demineralizes the enamel of the tooth and damages the tooth. And in this dysbiosis, there's an abundance of microorganisms that do typically three things rather well, and that's form a biofilm on the surface of the tooth that sort of helps to, the thicker it is, right, it traps the acid against the surface of the tooth and doesn't allow it to diffuse. And also, these organisms produce acid, and they also need to be tolerant to this acid, right? So if you have an environment that's acidic enough to melt a hole through a tooth, that's rather extreme. So you need organisms that can survive in that environment and keep damaging the tooth over time. Because if they all just died immediately, right, they wouldn't keep making acid and the damage would be self-limiting. And so S-mutans, of course, is for a long time thought to be the key causative agent of dental caries. And that's because not only does it do these things very well, particularly forming biofilms when we have sucrose, but also historically it was very easy to isolate and cultivate from caries lesions. And also it's very good at causing disease in animal models, including germ-free models, where all you add is S-mutans, right, and that you can get caries when the animals eat sugar. But since the advent of microbiome sequencing, we now know that caries can occur in the absence of detectable levels of S-mutans, but sort of what ecological relationships happen in these cases, we don't really know, and sort of the importance of S-mutans has been called into question. So we wanted to look at the oral microbiome using deep metagenomics, and there's a number of advantages to this technique that I'll highlight on the next slide. Sorry, I just had the same automatic updates thing try and come up as the other computer. And so on this project, I was working with Anna Edlund at JCVI and Rob Knight, who's across the street from us at UC San Diego. And in our study, we looked at 24 children with healthy dentition compared to 23 children that had caries, and we defined that by having more than 2 active lesions that had penetrated the enamel into the underlying dentin. So our rationale with that is that's a pretty advanced stage of the disease, right? So if there are big differences between the groups, we should see them. It's not going to be sort of a transition into the early stages of the disease. We collected saliva, and we did not only Illumina sequencing, but we also looked at host biomarkers using a Luminex assay. And so the main goals were to get abundance information of the species that were there using tools for compositional data, which is important, as I'll highlight on the next slide. And with metagenomics, right, if you also can get information for the functional pathways that are present. So if you imagine you're doing 16S, right? You have to sort of infer the genome that's associated with these amplicons, right? But if you sequence the whole thing, you actually know what's there. And you can imagine, right, different species within a genus or different strains within a species actually encode different functional pathways. There's differences. So you don't see those necessarily with certain types of amplicon sequencing. So we wanted to look at that because you could imagine that you could have microbiomes where the taxa are different, but the functions are actually similar, or vice versa. And so we also looked at the host immunological markers, which are mainly cytokines and chemokines, and we wanted to know what their co-occurrence was with the microbes that were present. And then also, as another advantage of doing deep metagenomics, right, is you can de novo assemble genomes from your data set and look for new species. And so whenever you do microbiome analysis, it's important to remember that this is all compositional data where you get relative abundances. And so this cartoon illustrates that. And if you imagine this microbiome where you have 12 orange and 12 blue bacteria, what you really see when you sequence is you take a sample of that. So you might get 6 of each. And what you'll really observe when you look at your reads is a 1-to-1 ratio of the reads from species 1 to species 2. And you can imagine 2 different events happening. And in one case, you get a death of a bunch of the blue bacteria. So now you have 12 orange and 6 blue. But you'll observe a 2-to-1 ratio. And you can imagine something very different happening where you have a lot more bacteria overall, but the orange increases more than the blue. Now you have 32 orange and 16 blue. But again, you're only going to see this 2-to-1 ratio in your sequencing data. And so that gets back to some of the limitations of using sequencing to identify disease progression and disease states, because you don't get the microbial load for sequencing alone, as Dr. Dutta pointed out in 2 presentations ago. So that's not only a problem trying to infer biological scenarios, but it's also a problem mathematically, because since infinite outcomes can produce this ratio, it complicates the generation of p-values. And so if you use traditional statistical methods to analyze compositional data, you'll probably have a lot of spurious results. So you have to really understand the limitations of this type of data and use tools that are designed to handle it. And at the end of the day, things like correlation and relative abundance in compositional data is an intractable problem. So it's good to use several tools and try and find overall trends. So what did we actually see when we did our sequencing? This is a beta diversity plot, and if you're not familiar with this type of figure, each one of the spheres or circles in the diagram is one of the subjects in the study. And so they're color-coded based on their DMFT score, which is the number of decayed, missing, or filled teeth. So you have the healthy study group is here in green, and then increasing severity of the caries from yellow into orange into red. And so in a plot like this, if the circles are closer together, that means their microbiomes are more similar. And if they're further apart, they're more different. And so what you can see is that sort of the general trend is some of the more of the healthy subjects group down on this sort of, or the negative direction on this vertical axis, and then the disease samples group more upwards on this axis. And what's also shown here are the taxa that are the largest drivers of this what we would call ordination space, or what the space of the graph. And so these are showing, for example, that the Prevotella and Veillonella are more associated with the positive direction on axis 2, so maybe with disease, whereas Rothia, Haemophilus, and Neisseria are more associated probably with health. And so using a tool called Churro, we can actually extrapolate the taxa that are driving the distances in this space. And yes, we see that Prevotella were the largest drivers in the positive direction, and Rothia and Neisseria and Haemophilus were more generally in the negative direction. But an important thing to notice, right, is these are color-coded by genus, and there's multiple bars with the same genus, and some are on the opposite side. So once again, it's important to realize, right, with microbiome studies, you want to be as specific as you can, and genus level data doesn't always tell you very much. And we know examples of that with caries, right? So strep mutans is clearly associated with disease and is a pathogen in the context of caries, but you have something like strep sanguinis or gordonii that's more health associated because they compete with S mutans but aren't as cariogenic. But they're both strep, so if you just look at a figure that says, hey, strep went up or strep went down, it doesn't really tell you that much. So that was just looking at the taxa driving the distances along that axis too. So it's what we would call an unsupervised method. But the next figure is similar, but it uses a deep learning tool called Songbird to actually look specifically at caries versus health. And we see a similar trend where the Prevotella were largely associated with caries, where Rothia, Haemophilus, and Neisseria were more associated with health. Interestingly, we now saw with this figure that S mutans was the taxa that was the second most associated with caries. And the reason why it didn't show up in the last figure is we actually only found detectable levels of S mutans in 11 of the 47 samples. And so that's why it probably didn't show up, but when it was present, it was significantly associated with caries. And one of the advantages of doing metagenomics, shotgun metagenomics compared to 16S is you get information for things like fungi and viruses, right, non-bacteria. And it turns out that the taxa that was actually the most associated with caries was human herpes virus 4, or Epstein-Barr virus. So we also looked at the functional pathways present in these microbiomes, as I mentioned. And so what this figure shows is we looked at 70 pathways, metabolic pathways that were present across all of these microbiomes. And we looked at how diverse these pathways were with both alpha and beta diversity. So each one of these 70 pathways has a point on this graph for healthy and a point for caries. And what you can see is that largely these data points are shifted to the left and somewhat down in the caries group, indicating that there was less diversity among these pathways. So what does that mean? That really means that there's pathways that are present in the health-associated microbiomes that are depleted in the microbiomes associated with caries. And if we just pick one of these pathways and look at it more closely that we can do with this type of data, here we're looking at arginine biosynthesis, and we can see that in the healthy samples, not only is this pathway at a higher relative abundance, but there's way more species present contributing different enzymes to this pathway. And that's what we would call contributional diversity. And so I chose to show arginine here because it's actually important in the context of caries, because a lot of bugs have an arginine deaminase that produces ammonia, and that actually is a basic molecule that helps to sort of buffer out some of the acid that causes caries. And so it's typically thought of as a health-associated pathway, and indeed it was depleted in our caries-associated microbiomes. As I mentioned in the intro, we also looked at 38 host cytokines and chemokines, and it turned out that there were 10 that were elevated in the caries group, and those are the ones shown here. And there were none that were higher in the healthy group compared to the caries group. And so we wanted to know, were there relationships between the different taxa in these microbiomes specifically and these molecules? So we used another deep learning tool called MMVec, which is for multi-omics analysis. And the results of that are here. And this is a rather busy figure. But in this case, the circles are now the host markers, right? The cytokines and chemokines. And if they're red, that means they were the 10 that were elevated in caries. And the taxa are once again shown as these vectors, but they're now color-coded on whether they were health or caries associated with our other data. And so what that means, right, is you might have this microbiomes that have a lot of EGF, which was higher in caries, also tended to have a lot of these Nanocinbacter and Veillonella, which were also associated with caries, but maybe some of the other caries microbiomes had things like TGF and CSF3, and they had higher Prevotella histicola, but not necessarily these other taxa and these other molecules as well. So what does this all really mean? It really just sort of gives you an atlas to further explore some of these relationships. So you can imagine the microbiome influences the host immune system, right, through immune memory and things like that, and then vice versa. The host immune system creates specific conditions, and the microbiome has to adapt to those. And so this might, this data is really helping you get started teasing some of those relationships out. So one of the other key advantages to doing the metagenomic sequencing or deep metagenomic sequencing is being able to assemble genomes from the data set. So from our data, we got 527 genomes that were at least estimated to be 50% complete. And so in this network, each one of the nodes in the network is one of these genomes. And they are a circle if they came from one of the healthy subjects, and they're a chevron if they came from one of the caries subjects. And each one of the nodes is linked to other nodes if it's equal to or greater than 95% average nucleotide identity. And so this is typically used by the microbiome field to estimate genomes of the same species. And so likely any of these nodes that are all connected in a cluster, right, they're all representing the same species, whereas, nodes where they're just a singleton, that's the only genome from that species in this study. So you can see there's, really common species like Preventella pallens. We got a lot of different genomes, and then there's a lot of singletons as well. But what's really exciting is many of these are yellow, which means that they are a known species, right? They are over 95% similar to something that's already in a database at the time, but a lot of them actually weren't. And so some of them that are in blue here are within a known genus, but they represent a novel species. And then some were even so different than anything that's currently in a database that they were not only a novel species, but it's likely they're a novel species within a novel genus. And so that's really exciting. Because we ended up getting these new species at the rate of almost 1 per person that we sequenced. And some of them were also rather prevalent, right? So if you look at the Solobacterium cluster here, or this Lacnospiraceae cluster there, right? These are over 10 different people in the study had these bugs, and they're not even in any databases at the time of this work. So there's still a lot of bugs that are even common, but we don't know anything about, and their relationship to health or disease. And so the last figure from the study is looking at Saccharobacteria specifically. So you'll notice we did get a lot of blue and green genomes from those groups. And so just briefly, Saccharobacteria is a member of this candidate phyla radiation. And so this is a tree of life of everything, right? So eukaryotes are this branch down here, and then up here is all bacteria. And this huge branch, candidate phyla radiation, has only been known for probably about 10 years, and most of the species we only know about from the existence of their 16S sequence. And it's thought that almost 30% of all bacterial diversity is included is inside this branch that we know almost nothing about. And so Saccharobacteria are actually only one leaf in that tree, but just within Saccharobacteria, there's a ton of diversity. And Saccharobacteria are one of the 3 groups of candidate phyla radiation that are common in the human oral cavity. And there are 6 main clades of Saccharobacteria, and most of them have been found only in the oral cavities of humans or other mammals, although the G1 clade has a number of species that are also environmental. But at the time of this work, there were only cultivated species were from this clade G1, and there were only a couple of complete genomes, or even they were within G1, and there were also hardly any even some of these groups. There's not even draft genomes yet. And at the time of this work, there were 2 draft genomes from G3 and only 1 from G6. But we actually got some rather high-quality draft genomes ourselves from this study, and so it enabled us to do a pan-genome analysis. And so this whole group is thought to actually the reason why they were so hard to cultivate is because it turns out they're likely all tiny parasites that live on larger bacteria. So for example, the first Saccharobacteria that was cultivated is a parasite that grows on an actinomyces host. So that's why they were hard to isolate, because they literally can't be isolated from the host. And they have a lot of things in common, like very small cell size and very small reduced genomes. And so when you have a draft genome, right, it's incomplete. So it makes it difficult to say what's inside that genome and what those species encode or might be doing. But if you start to get multiple draft genomes, even though each one individually is incomplete, you start to get more confidence about what's actually in those genomes. And so with the new genomes we got, we did a pangenome analysis. And so this is just a heat map showing, a heat map showing the presence and absence of the metabolic pathways in these genomes. And what you'll notice is that between the different clades of Saccharobacteria, there's actually very different pathways that are present and absent or encoded, and they have different metabolic functions. And so you could imagine if these were all originally a free-living organism, it almost looks like they lost different parts of their metabolism on the way to becoming parasites dependent on a host. I don't know why this keeps happening. As if we weren't hungry enough already, huh? Anyways, so those differences to me are really cool because they suggest that maybe these different clades have different hosts or they're dependent on the host for different things. And likely then they might have different roles in the ecology of the oral microbiome and human health and disease. And we don't know anything about them. These have never been, clades G3 or G6 have never been isolated. And as I'll show on the next slide, I used nanopore sequencing to get some of the first complete genomes from that clade. And I'm actually going to be giving a talk here next Tuesday at 9 a.m. if you want to come learn more about that. But using nanopore sequencing, I've actually been able to get complete circular closed bacterial genomes right from saliva samples, which is pretty exciting because normally you'd have to isolate and cultivate the bacteria in the lab to be able to get a closed genome or do downstream things like PCR to close the gaps. So please come to that and learn a little bit more. And I also, some of those Saccharobacteria are also increasingly associated with inflammation and disease, particularly in the context of periodontal disease. So they're probably important. So just to summarize, we found Rothia, Neisseria, and Haemophilus were associated with health, and that's in line with a number of other studies. And in fact, there's a gentleman in Spain, Alex Mira, who has a group that's developing probiotics using Rothia strains, and these are all nitrate producers, and so he's also looking at using nitrate as a prebiotic to prevent dental caries. In our study, S. mutans was only present in a few of the samples, but when it was there, it was very strongly associated with caries. S. mutans may be somewhat underrepresented in our data as well because we looked at saliva, not dental plaque specifically, and so S. mutans is so good at forming biofilms it's less likely to just be shed into the saliva, so we might have undercounted it. Epstein-Barr virus was associated with caries. That was really fascinating because that hadn't been reported before, so maybe there's some sort of relationship, but also active herpes virus infections and dental caries have a lot of common, factors that like low socioeconomic status. So it's possible that just environmental factors and circumstances are, why they are both prevalent in certain subject groups. The functional pathways were reduced in caries, the diversity of them. We identified the 10 immunological markers that were more abundant in caries, and we made an atlas of host microbe co-occurrences to be further explored. Again, we found novel taxa at a rate of around 1 per person sequenced. So even in a well-characterized microbiome like the oral microbiome, there's a ton of bacteria out there that we don't know anything about. We don't know anything about their antimicrobial resistance genes or their contribution to the resistome. And again, the Saccharobacteria clades encoded diverse functional pathways. And with that, I'll wrap up and thank the following collaborators and funding sources, and happy to take any questions.
Thank you, John, for the excellent presentation. So do we have any questions? Oh, okay, yeah. Oh, should I throw this one? Okay, I can just give it to you.
Thank you for a very interesting presentation. You said that the samples were taken from 6 to 11-year-olds. Was that correct?
That's correct, yep.
Is there any reason why you chose children? Because we heard earlier that the oral microbiome, like the whole microbiome, changes and becomes more stable in an adult. And can that mean that you would get different results in an adult population?
Yeah, absolutely. I would expect you would. I mean, the main reason, to my understanding, as to why we chose that group is we got those samples from the free dental clinic at UCLA, which largely treats children. And so that was probably it's never easy collecting clinical samples. So I think you try and make the path as easy as you can. And I'm guessing that for our clinician collaborators, that's probably a large driver.
Okay, yeah.
Nice one.
Excellent presentation, John. Just a very out of my curiosity, do you know where are we in the field and how much is still unknown in human oral microbiome? And do you think metagenomic is the way to go further to identify these unknown genomes? Are there some other techniques which will help?
Yeah, I mean, I think sequencing, obviously it'd be great if we could cultivate more of the microbiome and actually study them like physiologically in the lab, and hopefully data that we get from the genomes, like what the predicted metabolism might be, is going to help. But I mean, for now, definitely sequencing is the way to go. And as I'll talk about on Tuesday, nanopore sequencing is making it a lot easier to get complete genomes, as well as other long-read technologies. And so I think that's really going to help. And still just, sequencing more people and more communities and more conditions and getting more data and looking at it is really still what we have to do.
But don't you think we are already overburdened with the data that we have?
Well, probably, but I mean, yeah. At some point, we've got to, there's always going to be too many questions and work to do, right?
Yeah.
So.
Thank you.
Yeah.
Any other question? One more. Oh, you don't have to guess.
I'm curious about the Epstein-Barr virus and caries. Has there been any follow-up? And seems like something new. I understand you had all those caveats concerning how to interpret data.
Yeah. That's certainly something that deserves further attention. I think a lot of it is right. The majority of microbiome work done on the oral microbiome has been done with 16S. And so obviously that's not going to pick up viruses. So we have very limited, relatively speaking, a very limited data set on the human oral virome. I'm not aware of any other studies, but I have, at conferences and so forth, I've talked to a few people about it, and there's a guy, Gil Diamond at the University of Louisville, who has sort of some similar data and not published yet, and we've been talking about looking, comparing notes and looking at that further.
Do we have any other question? with that, I would like to thank you once again.
Thank you.
And yeah.
Thanks, everyone.
Have lunch and poster session now, and we'll all come back at 2:30. Yeah? Thank you.